Good morning, members. Just to advise that we'll start in a minute or two once the department's presentation has been set up. Thank you for your patience.
It was something to
Testing. Are we ready now? Thank you very much. Good morning, ladies and gentlemen. At this first meeting of the Standing Committee on Health, I would like to welcome all present, the members, departmental officials and guests, and also Minister French, who have joined us online. Welcome to one and all of you. I would like to ask the members to introduce themselves.
Thank you, Chair. Good morning, everyone. My name is Rachel Van Vogel, member of the Health Standing Committee.
Good morning, Chair. Good morning, officials. Good morning, everyone. My name is Christopher Fry. I'm a member of this committee.
Good morning, Chair. Good morning, everybody. Khalil Brankes.
Good morning, Chair, everybody. Dan Plato.
And I'm Gerrit Pretorius, member of the legislature and chair of this of the Standing Committee on Health. Can I ask the members online to introduce themselves?
Sorry, I didn't introduce myself.
My apologies. My apologies.
Thank you. My name is Moses Timberlake-Class. I'm also the member of this services, and I'm here just to represent the community. Thank you.
Thank you, member. You're so distant and so far from us, I missed you. My apologies for that. Could I ask the members online to please introduce themselves?
Thank you very much, Chairperson. I'm member Bakubaku Force.
We missed that. Could you please repeat?
Good morning, Chair and everyone. I'm member Bakubaku Force.
Morning, member.
Good morning, Chair. My name is Ayanda Barnes. Good morning to the committee and to the department as well.
Good morning, Noma French Mbombo, the MEC for Health. Thank you very much. And within here, there are people from the department who will introduce themselves. I see Dr. Karim, the COO. Thank you very much.
Thank you, Minister. Thank you, members. Could I then ask the departmental officials to introduce themselves?
Morning, Chair and honourable members. I'm Dr. Karim, the Chief of Operations.
Good morning, Chair and everyone. I am Nashina Furfre from Provincial Department of Health.
Thank you again to the officials for introducing themselves and availing themselves to be present here. I'm going to ask the members of the public to introduce themselves. Can we perhaps start on my left-hand side?
Good Morning, everyone. My name is Maulana Tawfiq Eli from the Mitchells Plain area.
Good morning. Good morning, everybody. My name is Nuran van Wyk, and I'm from the Athlone.
Morning, everybody. I'm Mildred Dumelam Shoke. I'm from YMCA in Athlone. Thank you.
Good morning, everyone. I'm Anthea Williams, YMCA Athlone.
Good morning, everybody. I'm Theodrico Light from Northern Tygerberg, NGO Touch Community Services.
Good morning, everyone. I'm Cornelia Kuhn from Northern Tygerberg, Touch Community Services, NPO, Pero.
Good morning, everybody. My name is Halima Isaacs. I'm from Manenberg. I represent the Manenberg People Center. Thank you.
Good morning, everybody. I'm Catherine Budboy. I'm also from Manenberg, also representing Manenberg People Center.
Good morning, everybody. I'm Leslie Sylvester, and I'm from the Klipfontein Sub-District Health Forum. Thank you.
Good morning. I'm Kathleen Daniels, and I present the senior from Manenberg People Center.
Hi, I'm Liz Huckle from Hart Bay Clinic Committee and Health Forum.
Thank you to all the members of the public again for your presence and for introducing yourselves. Are there any apologies that we should take note of?
No apologies, Chair.
Thank you, Ms. Jamche. With that, members and guests, member class.
Yeah, I want just to have clarity because I'm new. Those who are the public members are invited, or are the members just voluntarily to come here? Thank you.
What was the question?
Is asking if those members of the public, if they are invited.
And were they invited? Ms. Jamche?
Committee meetings are open to the members of the public.
Thank you.
Thank you, Member Klaas. With that, we hand over to Dr. Karim through the Minister, if that's in order, for the presentation on the home community-based care services in the province of the Western Cape. Dr. Karim.
Thank you, Chair. I wonder if Minister, would you like to make any opening comments?
Yes. Thank you very much. Dr. Karim, yes, will do the presentation with the team. But I think, Chair, it will be probably appropriate for me just to provide, just in 1 minute, in terms of the background of community-based care services in the, as a form of the packages that South Africa is provided. So it was only in 1997 white paper where during the time of in the new dispensation that South African health system was working on having these different packages of care. And it was only the community-based care services using community health workers as part of the packages. It was only during the 2010 in regard to some of these kind of services, adopting a model coming from Brazil. I was one of the people who were working around this model at the time that I was a consultancy for the National Department of Health. For the Western Cape, we made it as part of the packages of care, be it like a transitional, whether it is a step down or it's a step up, and also trying to make sure that we continue with the multi-sectoral and intersectoral collaboration of the civil society as part of that, whilst we're waiting for the National Department of Health to come up with the correct models. As you are aware that across all provinces, the community health workers as the main drivers of the home community-based care services is still disintegrated. There's still nothing, it's still being under the discussion. And Chair, now what happens was about for us who are adopting, which is what Dr. Karim is going to present, the community-oriented primary care, which takes us back to the basics of 1938, where South Africa has been the pioneer of the community-oriented primary-based care, which inclusive of the civil society and all other stakeholders that are involved in those kind of communities. So what I'm trying to highlight is about, we need to differentiate between what is it about home and community-based care services with who are the people, who are the drivers who needs to be providing that care, and also in context of what is happening currently in South Africa, which is the last time we had National Health Council, it was about it's being taken back to the Department of Labour, because there still hasn't been any clarity. And then lastly, Chair, take to note that the part of the phase 1 of the NHI, I think we're in phase 2 or 3 now, because we're busy with the legislation. Part of it's one of the principles or 10 areas that were supposedly to be piloted of using the ward-based community health workers to be allocated per ward as part of going towards the fully fledged NHI. So I thought, let me just provide that kind of the basics so that as they present, to understand that there are different modalities, but the principle is still the same. Thank you, Dr. Karim. Over to you.
Thank you, Minister, for that very thorough, brief introduction. With that, over to Dr. Karim, please. Thank you.
Thank you, Chair and honourable members. Minister, so essentially we'll outline, as much as I'll introduce myself, I'm the Chief of Operations, and I've got Dr. Furfrey with me as well, who's also from the department. So what we'll outline is our background and strategy. We'll look at overview of our current services and then where we're now with community, home and community-based services. But just by way of very brief introduction, because we also have members of the public that have joined us, we have a plan, Healthcare 2030, the Road to Wellness. It's our North Star. It's our plan for towards 2030, and a number of the initiatives from a strategic point of view are listed in the plan. So it's a useful document for us, and it's a good reference document. But as Minister mentioned, COPC, community-oriented primary care, is really one of the bedrocks of our strategy. And this is a homegrown South African concept. And I'll come back to community-oriented primary care in a minute. But just very briefly at a high level, the overview of Healthcare 2030, I mean, what's quite important for that and how it interdigitates with the conversation and the presentation today on home and community-based care. It is a very health person-centered approach. We take the life course approach. So in other words, we take it from basically from birth all the way through to death, literally. It's an integrated approach. And also we look at the continuity of care. And that essentially, as I said, is our long-term strategy, and it focuses on health and wellness, which we are now, Minister gave us the good news yesterday that we are now officially the Department of Health and Wellness. It's something that the Minister has been driving for a long time. So it's a focus on health and wellness rather than diseases, and I think that's quite key, but also obviously looks at the quality of life. And what's also quite important in how this relates to the conversation this morning, the presentation this morning, is around self-management and self-care, and it's quite a key concept in Healthcare 2030. But essentially, and I will take from each of the slides just maybe a few of the points rather than go through each and every bullet, because it might just in terms of time. But Chair, you can just guide me from a timing perspective. But essentially, some of the key tenets of health is everybody's business is we want people to obviously live longer and healthier lives. I mean, that's really ultimately the bedrock of it. We know, for example, that in terms of drivers of health, clinical care is only 20% of the drivers of health. 80% are in fact behavioral, environmental factors, etc. We want to know and people to know that we know that they do matter. Every human contact has. We want people to have a sense of pride, of optimism and worth, and that drives a lot of our service delivery strategies. We want a health system that's people-centric, trusted and equitable, that's caring and competent, that has an empowered workforce. We focus quite strongly on clean governance, and we'll come back to governance around home and community-based care, but this is quite a key concept for us. And obviously, we want to be innovative and accessible and have a really health system for you, which is part of the provincial government drive. And clearly, we would like to make sure that we're providing the right care at the right time, at the right place, at the right price. We've got a concept of do, be, and become, of what we do, how we are, and what we'd like to become, and I'll come back to that in a minute. But also, we obviously want to work, more importantly, with community members. We want to work with yourselves, with partners, whether it's the private sector, community, or HEI partners. We'd like to work with everyone in order to make sure we have a healthier society. The next slide just looks at service transformation in terms of what are the key priorities. And as I said, wellness and health promotion and prevention of ill health and injuries is really a critical focus of our drive of the strategy of the Department of Health. And really, it's part of the primary healthcare re-engineering approach, and that's obviously aligned to our 2030 strategy. But the bullets there just gives a sense of the kind of priorities that we focus on in the plan. And we've just lifted out some of them, like reducing infectious diseases. We've got the 90-90-90 targets for HIV and TB, which, as you know, we're busy revising to 95-95-95. But we also focus very strongly on improving healthy lifestyles. So this really comes out quite strongly in our focus towards 2030. And that really is part, and we've got various programs that does that, but really it's through community behavior change and healthy choices, or healthier choices. We've got, for example, our WOW programs that you might have heard of. Preventing injuries and violence is quite a key element and tenet of our plans. Improving maternal and child health, strengthening women's health, and improving mental health are also other critical focuses. But essentially, improving healthy lifestyles and wellness is really comes out very strongly in the Healthcare 2030 plan. I said I'd come back to COPC, and really this is at the basis of our service redesign, and we are at the moment, in fact, engaging in a process of looking at our service platform now that we're exiting COVID, and we are looking at redesigning our service platform in line with COPC, and this is really a key principle of and a tenet of our strategy. But just by looking at the definition of COPC, you'll see there are a couple of key words to lift out. First of all, it's a continuous process by which primary care is provided to a defined community. So it's quite clear that it's a very specific, localized, geographically localized community on the basis of that community's health needs. So it's not the same in every community, and it's quite important that we have a process of assessing those health needs. And then obviously the planned integration of public health practices, delivery of primary care services, how that works as a composite. We've just now signed off a circular, and we've on COPC, which is our position statement on COPC. As the Minister said, this is towards UHC. So I just signed this off in the week, in this week past now. No, actually it was last year. Sorry, towards the end of last year. I'd signed it off already. And we're busy updating, obviously, some of the concepts and having conversations with our service platform around COPC. But looking at home and community-based services, coming more closer to the specific topic at hand, I'm first going to look at the integrated health and wellness package in the community. As Minister said, we've been working for many years in the Western Cape Province and providing guidelines to NPOs in terms of what that package of care is that we'd like to be delivered at home and community-based on our platform. And there's it's a different, wide variety of interventions that essentially supports people's actions to maintain healthy lifestyles and well-being, prevents illness, manages disabilities, caring for minor health problems and long-term conditions. Chronic conditions is really a critical part of our approach. Assisting recovery from periods of acute illness, injury and or hospitalization. But we've also added in there home-based palliative care and supported end-of-life care. And those are also quite key concepts. Obviously, during COVID, we found that this is obviously one of the areas that we were lacking, and we strengthened that in the processes going forward. And I'll come back to the NPO call for proposals as well. But looking at what the services are that we want to offer, it's screening and referral, where applicable, obviously, assessing people, doing care planning and interventions and treatments, as well as monitoring and review. And you'll see there in the diagram on the left, the pillars of primary healthcare really that it speaks to. And so it's a whole comprehensive package that we really want to make sure we are able to support people in their homes and in their communities. So, but essentially in terms of a process, what we normally do is in assessing the client's needs within 3 working days of referral by a clinician. Then a structured plan gets developed within 5 working days following that assessment. And then obviously professional nurses monitor and review patients at regular intervals, but certainly no longer than 6 weeks. And then, as I said, if someone's condition worsens or we find that they're not adhering to their medication or their treatment, then they get referred back to the primary care services. And all of that obviously is supervised by our professional nurse cadre of staff. We've had different types of community health workers, and we've been through a process over the last few years of combining and consolidating that. Dr. Furfley has been leading us on that. So, for example, you would have heard the name lay counselors. That's a program that was started 25 years ago. I remember because I was the head of HIV at the time we started the lay counselor program, focusing initially on HIV counseling, but obviously it was meant to have been in a more integrated program and not remained as a vertical program. And then there are other cadres of community health workers. But the intention that we really want to do is try to bring all that together so that from the 1st of April of this year, for example, the previous lay counsellors would then be trained to provide the full package of home-based care. And we really want to have this comprehensive cadre of community health worker that can in fact do all of this, so that we don't have all these vertical different types of community health workers. And community health workers in turn will also, with home-based care experience, they then get upskilled to provide the counseling services again. So it's all part of our comprehensive package of care. I must mention the sectoral determination in the bargaining council, because obviously that's quite a key pivotal point in this whole development of community health workers. And Resolution 3 of 2022 was reached in the bargaining council, and in that resolution the stipend was agreed upon, because before that there were provinces were paying different rates. And so now there was, from that resolution, an agreed upon stipend, and we've obviously implemented that in the Western Cape. Obviously, there's factors of growth over time, but we have implemented that. Also, in a sense of, a part of the agreement, all the parties signed the agreement had agreed to negotiate the modalities of the agreement and to conclude that by no later than 31st of March 2025. Our view, in a sense, in terms of those modalities and making sure that will ensure uniformity across the community health cadre, across all the provinces. But also, I think what's important is developing standard operational procedures so that we're all following the same recruitment, selection, placement, remuneration, skills development, etc. We have had quite a number of conversations in the Western Cape, at least, about skills development and making sure that we're trying to upskill people as much as possible and what the needs are, based on the COPC approach and based upon, as I said, those defined community needs. But essentially, we will obviously await the outcome of the sectoral determination before we make any decisions whether to absorb the community health workers into the department. I know this has been a point of conversation in the legislature before, and obviously we'll wait for the outcome of that. Our model is to employ the community health workers through the NPOs as opposed to employing them directly into the department. And we do believe that model works well. The funding, just in terms of the funding, is via our conditional grant, and there's also funding available for training. We also take a small amount from our provincial equitable share, and we also employ some of the community health workers through that basis. But obviously, essentially what we're trying to aspire to is appointing 10 community health workers per 1 nurse. So that's sort of the ratio that's nominally accepted right across the world. And that's where we really want to get to. At the moment, we have roughly about 3,900 community health workers in the Western Cape province. So we've got quite a large cadre of community health workers that then supplement the work that's done by our nursing staff and our medical staff. And that's obviously quite an essential component of our service platform. And in fact, it's something we, in our strategy towards looking even beyond 2030, towards 2045, we in fact plan to grow that service platform. As I said, our NPO model, we believe, works well, and the recruitment and selection of staff is then done via the NPOs. But essentially, it's a multidisciplinary team that provides support to the NPO teams that we've got. So we've got a team of people in our facilities that obviously then provide support to the NPOs and through the community health workers. What are we hoping to achieve? What are the goals of our service? As I mentioned, there are two elements to that. It's both community-based services and wellness services. And this is important because it really sets the tone for the NPO structured packages of care document that we put out and the call for proposals. So it's both elements, but obviously the key focus, and it would range from prevention, promotion, cure, rehabilitation, and palliation as well. But obviously trying ultimately to empower people that they can take care of their own health at home. I won't go through all the detail on the slide, but as I mentioned, it's right across the life course, but also across the burden of disease. And there are identified key populations that we have want to focus on. So if we're looking at across the life course from children through adolescents to adults and to the elderly, right across the burden of disease from people who are mostly healthy to people who have defined episodes of care. And we call that defined episodes of care because this is perhaps a single episode that someone comes into one of our facilities and I'm not well and I need care. And obviously if that progresses and worsens, it becomes a chronic condition and that's over a more prolonged period of time, but it could also be very disabling and that might require prolonged care and specialist care. Those are some of the key populations that we're going to be focusing on. Working in prisons because they're a really high-risk population group with sex workers and truckers. There's a campaign's been going on for many years. Farm workers and migrant workers are quite important, particularly for the rural areas, but also the various range of the LGBTQI plus community, and then also people who inject drugs. That package of care, in a nutshell, is focusing on maternal and newborn health. It's focusing on sexual and reproductive health, healthy adults and aging, but also child and adolescent health. And that kind of gives one a visual impression of what the packages of care look like are like. This slide then shows and breaks those down into each of what are those activities that we'd want to be focusing on in maternal and child health, for child and adolescent health, in the sexual and reproductive health area, and for healthy adults and aging. So I won't go through all of the details, but you'll see in the slide, for example, there are home visits during pregnancy. For example, they are promoting birth preparedness, there are postnatal home visits, there are vitamin A, deworming, immunization. We're busy with this campaign literally as we speak. As you know, we've started a measles campaign that we've now administered since the 6th of February, roughly about 207,000 measles vaccine to our children because of the measles outbreak and the Cape Metropole having declared a measles outbreak. But also in the area of sexual and reproductive health, there's a whole range of preventive activities that we obviously conduct, everything from distributing condoms to counseling HIV, providing post-exposure prophylaxis and pre-exposure prophylaxis, and in healthy adults and aging, there's again a whole range of communicable and non-communicable diseases that we focus on. So looking at the wellness part of that package of service, this is really a comprehensive package of care. I think the difference is it's provided where people live, where they learn, in their social environment and in their working spaces. And it's something that the ministers have also focused on for many years already. And we have opened these wellness hubs across the province where we want people to come in and whether it's health promotion, whether it's HIV screening or blood pressure tests or glucose monitoring, a range of activities that will help people understand where their health is and what needs to be done. And those could happen really anywhere. It doesn't have to be in a facility. It could be a mobile service, it could be at a taxi rank, it could be at a sports club. Coming down more specifically to the actual package of service and the call for proposals that I mentioned, we then go out every year and we do the call for proposals every 3 years, but it's essentially partnerships that we create for delivering the care package that I've spoken about earlier now. We've just put out a new external call for proposals. I'll come to the timelines and show you where we are at with that. But essentially, it does allow us to align the services that the NPOs are providing with our provincial priorities, but placing a specific emphasis on COPC. So what we normally do, invite NPOs to submit proposals. We just had a big workshop with about, I don't know, a couple hundred people. Probably about 800 people. No, that's me. Probably about 500 people. We had all the NPOs come, and we basically explain to them our process, and we do this at regular intervals, but making sure that they obviously understand the process, that they can submit proposals. We have to comply with all relevant legislation, and then there's annual structured evaluation of their partnerships that are based on performance, because that's quite important, and obviously the contracts can be extended for 3 years. This just outlines the packages of services in the metro and rural, essentially those similar to the ones that what I've mentioned. I just want to focus a little bit on intermediate care as well, because intermediate care, by definition, in our call for proposals, obviously, we'd like to focus on that as well, as part of a learning that come out of COVID that we've spoken in the legislature about previously. But really, it's essentially on community-based services. It's intermediate care, it's community mental health, the high transmission areas. The rural also has got a nutrition element to that. But those are really the elements of the package, service package. We had a process, went too fast there, sorry. So we had a process in the metro and rural that were actually quite separate. And as I said, we're trying to pull all of that together and close the loop on that by essentially, and we had extensive consultations with that. So essentially, we now have one consolidated NPO package for the whole province. Because previously, the metro focused on the block on the left and the rural focused on the block on the right, and it wasn't right. And the rural also had nutrition projects, etc. So we've consolidated that into a single package. Service package for the province that we want to say to the NPO community, this is what we'd like to achieve. And that package then obviously has those elements that I've now mentioned. That's integrated health and wellness, those two elements, community-based services and wellness services. The transitional care, which is just renamed, and a little bit of a deeper intermediate care process. We've called it transitional care. And we also have, in fact, a transitional care policy in the province. There's community-based mental health. That's really quite critical. In the legislature, we've previously addressed the legislature on the pressures post-COVID, and mental health, as you know, has been one of those service pressures. Nutrition projects I've mentioned that were in rural and in the high transmission area projects. Those are just the focus here. So that's one consolidated service package for the NPO funding for this year for both metro and rural, and we're quite happy with that process now. I've added the slide is just to make sure it's the alignment of the NPO service package with the various strategies. The bottom you'll see our do, be, become. Do is essentially what's the service redesign journey. How we are is our governance and culture journey, and our aspirations is what we'd like to become. So just to make sure that the NPO package that I've spoken about, the consolidated package, aligned to the various strategic documents and strategic direction of the department. Post-COVID, from recovery to reset is also part of that package, that service redesign, and there are a couple of key areas that we focus on. There's the service platform redesign process that I've mentioned, where, for example, home and community-based care is part of the future care continuum, but we'd like to, in fact, expand on that. So we want to grow that part of the service package. And in fact, when we do all of that, we're hoping and experience has shown around other countries that when you expand on those and other elements like ambulatory care, you can, in fact, reduce the inpatient care because people are living healthier lifestyles. And then the other documents you'll see at the bottom, you'll just see is our part of that service delivery package. But essentially, this is what we provide the NPOs, and we give them an understanding of what the strategic direction of the department is, that when they submit proposals back to us, that can be in line with that strategic direction. And again, as Minister mentioned, ultimately it's towards achieving universal health coverage. I said I'd come back to the timeline, Chair, and this is just the timeline, so where we are at. Machina's nice big green ticks here. We finalized the service package. We've put out the advertisement, the external call for proposals. That went out, as the members of the public would know, in December of last year. We've had the briefing sessions in January. The applications closed on the 20th. And obviously at the moment we will then finalize the outcome and adjudicate on those applications. And then from the 1st of March, we'll begin preparing those contracts for signing so that we can start the process immediately. Like I mentioned, we will do the annual reviews, and it will run for a period of 3 years. So essentially, we contract with the NPO to provide those services that I've mentioned in a geographical area as part of that comprehensive package of care. And then obviously we have a process of adjudicating these submissions and making the decision, and then ultimately beginning the service. The last section I'm going to look at, Chair, is just the governance issues. I think that's quite important. And we've, as I said, we've made focus on this for a long time, part of our clean audit in the department. But I mean, NPOs obviously have to be registered. There's legal tax certificates and other legal documents they must comply with. And they then will be responsible for governance in that geographic area. They'll be fully responsible for the HR management. Obviously, we provide training, as I've said, and staff must be available to attend that training as well. But we want to also make sure that there's compliance with the regulated norms and standards. This is the Office of Health Standards Compliance, because that's also part of the legislative framework that we have to work within. And then working within the substructure or the subdistrict, and making sure that we're providing linkages to care. One of the areas, for example, are TB and HIV patients that we found. I think there's roughly about 20% of people who have they just out of the system. We know that they're positive, but they've just disappeared out of the system. So providing, ensuring that linkage to care. And then there's statistics reports and monthly, quarterly reports, and we monitor those. Dr. Furfrey's unit monitors those very carefully in terms of producing outputs that have been agreed upon in the contract that have been signed. There's a whole range of clinical governance issues that I won't go into, Chiefs. I think my time, I sense, is running out. But obviously, there are a whole range of clinical governance issues that we have to make sure. Like, for example, if there's medications that must be stored safely, if there's infection control, we've got to adhere to infection control procedures, and we actually obviously monitor that when we do the assessments as well. This is just, we've got some funding guidelines, and in terms of each of the different areas, what the projects would be and what we pay essentially in terms of the categories, like traveling, like auditing fees, like in-service training, allowances for uniforms, and obviously for management. In conclusion, Chair, I mean, I think essentially it's important that with home and community-based care conversation and focus on that it's a quality service that provides, that make focuses on the patient experience. That really lies at the heart of our 2030 and lies at the heart of this whole process for us. And we'd like to reorientate our health system towards being a more person-centered health system, designed around the needs and expectations of people, but obviously exploring a wide variety of initiatives that, as I mentioned, that can essentially increase access to preventive, diagnostic and treatment services. And that's why our partnership with the NPO community is actually quite crucial for us in the province, because we do believe that the NPOs are close link to communities that they serve and have a better understanding than we do, perhaps, of what the local needs are in a specific geographic area and a specific community, because we believe and we still believe that model is the better model, rather, for example, than us employing as community health workers into our system. But that's the bargaining council chamber process. But ultimately, in conclusion, I mean, it's the home and community-based services is an opportunity to provide that person-centered care that we talk about, and making sure that it's relevant, it's socially relevant, and that it's responsive. I just want to acknowledge my colleagues, Dr. Goeieman, Dr. Furfrey sitting next to me, Ms. van Staden. These are some of these are stalwarts in our department. They're the ones that go through these contracts in detail and look at the line items and make sure that that the service is being provided, and that also at the same time, when we come to auditing, that we can actually stand our ground and whatever auditing processes are we have to comply with. Thank you, Chair. I'll hand back through the Minister. Back to you.
Thank you, Dr. Karim. May I just at this stage also welcome the additional members of the public who have joined this meeting. We will now proceed to questions and answers. Just for clarity's sake, for the members of the public present, The members in the House and online will get the first opportunity to ask questions, which will be responded to, and after that, members of the public will get the opportunity to pose questions. Thank you very much. Members, questions, please. I see Member Plato, Member Windvogel, and Member Fry. And Member Klaas, my apologies. Shall we take those 4 questions first then, please? Member Plato.
Chairperson, thank you very much. I also welcome the presence of the members of the public. I think the presence is an indication of how important this topic is. Very, very important for our communities and for the NGOs involved in the health issues and situation in their respective area. I also want to applaud the Minister and her team, Minister Noma French Mbombo, for this care package. I like the package, I like what I see, so I'm not going to ask a question, I'm just going to give a little bit of input and context. It seems to me a real improvement on the previous package, and I think why I'm saying I applaud the Minister, it is important that we try as departments to do better and to improve, and it's exactly what the Department of Health are doing. And this is what our communities need. And I want to say, Chairperson, especially our disadvantaged communities, it's so important for them because health and social issues in our communities is massive. And I'm very pleased Dr. Karim also put some focus and emphasis on the mental health issue, because as a result of the social issues and other issues facing them, poverty, unemployment, and the disadvantaged nature, it crystallized out for family members and people, and specifically for fathers and so on, to become mentally attached, and then you can see the mental issues and where it originated from. It's as a result of that. And what I pick up here is that it is exactly what the Minister want to address. It's complex issues, but we need, as a department, need to start somewhere. I want to round off to say that it cannot want to be the Department of Health alone. It needs to be integrated. Integrated approach, social development and others needs to play its role, and I think that for me is key. Thank you, Chair.
Thank you, Member Plato. Member Windvogel.
Thank you, Chairperson. I also welcome the presentation from the department. I just need clarity first, Chairperson. The Minister says, if I hear correctly, that the NHI make provision for healthcare workers working ward-based. And Dr. Karim, you were saying that you just signed off. So I need clarity on that issue. Then secondly, Chair, so I really need to understand what it means. And secondly, Chair, I think the department's goal is to provide the right care in the right time, in the right place, in the right price. But to get to that goal, we need happy workers. And these healthcare workers, it's always something close to my heart. There's negotiations up there, busy negotiating in terms of the salary package, and we need to consider cost of living. And my view is it doesn't matter if that agreement or negotiations is not finalized. As the department, normally if you look at the minimum wage, it's not saying you must not pay them more than a minimum wage. It's only saying you must not pay them less than a minimum wage. So as a department, I think we can do much better to look after our healthcare workers, because they are the people who are there always 24 hours. And I really appreciate that. So, Chair, I also need to need clarity on that. And also the other one is, do you have a section where you will assist these NGOs to be compliant? I think I will park there, Chairperson. Thank you so much.
Thank you, Member Windvogel. Member Fry.
Oh, mine is on. Apologies.
Member Fry.
Thank you, Chair. Thank you for the presentation. I welcome it as well. I just have one question. The ratio of community health workers to nurses is 10:1. Is that going to be the same in the rural areas as well? Because in our latest cluster visit week, we saw that there's an immense need for healthcare facilities and primary healthcare in the rural areas, which is not being adequately addressed for a myriad of reasons. So I just want to know if the ratio will be the same, or will it be actually? I think it needs to be a bit more in the rural areas. Thank you.
Dr. Karim, my apologies. I should have said that we're first going to take the questions and then give the opportunity, if that's okay with you. My apologies. Member Klaas.
Thank you, Chair. My apologies is that I'm new. Some of the questions maybe can be irritating, but I'm just trying to understand exactly what is happening. First question that I oppose that I want to ask is that we see you said that you are on a point of closing date. And on that closing date, my question there, are you going to employ them, or are you going to give that NGO geographically, or on a base of race, or on a base of need? The reason I ask is that they also question even posed that how much they will earn, because something that is difficult, we give people peanuts. We said that is because they are assisting the community, but how can you assist the community and then you get peanuts? Peanuts is just, it's look nice, but there's not big taste there. Two, I would request that when you do that, I've mentioned there is some of areas that are here, Athlone and Miningberg and all others. I would like when you do a checking or you prove that NGOs or NPOs, please check that all the geographicals are there attendant, and not saying that they don't qualify. As I mentioned there, one of our member mentioned that you must have a skills to develop these people, rather than saying that in Athlone there's no one because they are not in the skill. So try also say, okay, we need a person in Athlone, but there in Athlone, at least there is someone who's close, let us kill him. Not move away and saying that, you are not qualified on other. So in order for us to see the health is moving around all over. Thank you.
Thank you, Member Klaas. Minister, do you wish to respond before Dr. Karim responds?
Yes, thank you. And unfortunately, now the 2 hours on load sharing, I won't be able to do the camera. If I could just, I'm not going to respond to everything. I think it's also, Chair, is crucial because the community is here. Some of what you are asking, we as MPLs might be familiar as standing committee, but we also need to provide some more of information for the community because it's not their language of day to day. Just on the question from Member Van Vogel about the clarity, because I mentioned NHI and all of those. What I was trying to highlight that in as much as that South African health system in the post-democracy, they were trying to realign all the health services using a primary health care stroke district health system model. The issues of services that are happening outside a health facility, which is specifically in this case, home and community-based care services. It didn't take much beyond only on paper until when now they came up with the NHI as strengthening the primary health system as a phase 1, which is the to 2017. That is the phase 1 of NHI as a piloting for strengthening primary health care. I'll come back now to in terms of what exactly that they are saying they are strengthening. And now the phase where we are for NHI is a phase 2018 to 2022, which is the bill, and the amendments is all about legislation that are busy with. And then the last phase, phase 3, 2022 to 2025 or stroke 2026, is about the whole issues about the taxes, where money will be coming from and so forth. So now what is happening is about now with the home and community-based care services, part of the 10 issues that they were driving at the time, it was 1, ward-based primary health care outreach teams using community health workers as part of. And then the others, of course, about the school health programs, the GPs contracting, the ideal clinic realization, the district clinical specialist teams, the centralization of the chronic medicine, patient registration, stock visibility, infrastructure, and also the issue on the human resources, which is the workload indicator for staffing needs. So they were focusing on those 10, but all of those 10, not many. Actually, the report showed that actually there wasn't much that happened. Now, on the issue of, in this case now, on the ward-based community health workers, they came up also with a service delivery kind of agreement in relation to how this should have happened. But it was the first time that, and they went to Brazil in terms of copying and pasting that. But unfortunately, we're back to square A in this regard, because at this stage, the National Health now has to take it back to the Department of Labor, because what was envisaged, it ended up being difficult to implement them as part of the formal health system. Because 1, if you end up employing them, which is the case in other provinces, it means actually we are breaching the principles of primary health care, because they shouldn't form part of the formal health system. They should form, they must be, inverted commas, to be owned by the communities. But the issue is about how will they be able, communities be able to own them in this case. Hence, you'll find that the NPOs become the ones who are currently the vehicle where you could be able to make use of them. And then lastly, Chair, if you look in terms of the different models in the Western Cape government of using packages coming from the NPOs as the service providers. Previously, I used to be the MEC for sports and culture. There, when you do the advertisement for the NPOs or NGOs or community-based care in terms of they can be able to, whether you're doing culture and whatever, it becomes an open kind of a system where you can say that, Mbombo NPO is doing this, let me apply. And then they continue with their own thing. Similar with, but in the case of the health, it's about, this is the package that needs to be provided. And it should follow this kind of format, because it feeds to that clinic, because they are linked to the clinic. It feeds to that clinic part of the package. Like in Khayelitsha, when you even have the catch and match, community workers where they'll go and they find a child or whoever, and then they could be able to transfer and register that person if it needs, for example, social grant. So it's about the predetermined packages, evidence-based, and then that's why now say community workers, that's what they're going to do in order to be able to advance what is supposed to be provided. So I'm trying to make a distinction. And then lastly, Chair, is about, again, as I indicated, it was last November, I think so, the National Health Council, where now it was about, we have tried as much as we can, it has to go back. And there was a time that during the then National Minister, Dr. Mutsualedi, it was about, I think it was after the resolution one in terms of the 2018, part of the Bargaining Council, it was about one thing that we are not going to, it's non-negotiable. It's about that we cannot compromise of. It's about the minimum wage, which is what member Penfochel was mentioning, which is that's where for us we have to also to revise is that wage is there. But the issue about whether they'll still be part of the abnormal PESAL, just making an example, like in the Eastern Cape, they'll put in the PESAL and then they put in inverted commas about AB, like it's abnormal PESAL. In Gauteng, in KZN, and in Mpumalanga actually, where they actually, some of them will find that it bloated the whole HR. So it will make as if you have got 75% of the staff because they are being included. So hence we'll find that everyone has to revise, but we are all on hold until we hear what's going to happen that is coming from the Department of Employment and Labor. Thank you, Dr. Karim. I think the others, the department could be able to answer.
Thank you, Minister. Dr. Karim.
Thank you, Chair. Thank you, Minister. So I'll just start with Member Plato's ones perhaps first. The mental health focus, absolutely, Member Plato. This is really quite a key focus area of the department and also found its way in expression into the NPO call for proposals, because only together with our NPO partners and the rest of the other government departments like social development, etc., can we in fact have an integrated response. So we have other processes with our colleagues in social development and education and the other departments as well, where we have these conversations. But the intention is, in fact, to go as a whole of government to a community and have an integrated response to the needs of that community. And we're quite excited by that process because it's the first time that approach is being taken by the government. Member Windvogel, Minister, answered the NHI question, perhaps the health worker, the pay. Absolutely. I mean, we'd like to pay people as much as we can because they really do deserve it. You know, obviously within the confines of the budget conversation, which we will be having in the legislature pretty shortly again. Issue of compliance and NPO checking, we certainly do, and that's the unit. There's our unit, a very small unit, it's about 3 people, but we do make sure that the NPOs comply with the contract that's been signed in terms of the deliverables that's been agreed upon. And it's an iterative process, and then obviously that is then happens at the geographic local substructure level. So they are not just in the centralized provincial office where Dr. Furfrey sits, but also in the different geographic areas. There are people who then make sure that NPOs comply with the contract that's been signed with them. Member Fry asked about the 10-to-1 ratio. Absolutely. I mean the issue we'd like is an aspirational target, and like I said, we intend over time expanding the home and community-based care platform, depending on how the budget process allows us to. But we really would like to get to obviously a better target in terms of ratio of community health workers to our nursing staff. Rural areas do have a particular challenge. You're absolutely right, because of distance and various other issues, socioeconomic factors and a whole range of factors, that rural areas there are more challenges. That way. So we will obviously would like to look at the ratio in terms of the rural areas as well and see what the budget allows us to do. But the 10-1 is an aspirational target. I'm going to ask Dr. Furfrey just to respond to Member Klaas about just explain the process in terms of assessing the need per geographic area, because that's quite important, so that we understand the nuanced differences, say, between Klipfontein and Mitchells Plain. It's not the same community, and the needs are not going to be the same. So there's a process that we engage with through the department in those geographic areas. But perhaps Dr. Furfrey can just explain how that works.
Okay, so even though the package has been provincialized, so we don't have separate packages for rural and metro, the service teams within those geographic areas were integral in developing the current service package. And when we did the call for proposals and the briefing sessions, there were separate sessions done in the rural areas. So each district had their own briefing session, and then the metro had one, combined one. But in saying that, the information that was then shared with the NPOs was really the meticulous work that was done by the various teams. So how the CHWs or how the NPOs are appointed is really based on the need in a particular area, the population within that area. So for CHWs, for example, one CHW needs to see an average of 200 to 250 households need to be responsible for that. So each area, as Dr. Karima said, would have different needs based on what the burden of disease is, what the population is, and then each geographic area is also divided into specific nodes, and each node would have a different need. So it's very difficult to explain it, but it's very technical. And each team within each district or substructure in the metro had then worked closely to determine for their specific area what it would mean. This was all communicated to all of the NPOs who attended the briefing session, so they would have been able to submit a proposal based on an area that they wanted to service. And then in terms of adjudication, there's also a strict process where there's a scoring. So it's a non-biased process. It depends. Everyone gets the same brief. Everybody has to attend, gets the same information and the same opportunity to submit a proposal, and they are told exactly what needs to be included. So the adjudication process in terms of how NPOs are then appointed to a particular area is decided on that. And it's not a single person that makes the decision, it's teams from the specific geographic areas that sit together and make those decisions. So I'm not sure if that answers your question or if you want more clarity.
Thank you for that, Dr. Fafi and Dr. Karim. I see that Member Baku Baku Vos's hand is up. I presume that is for a question. Member Baku Baku Vos.
Thank you very much, Chairperson. I'm already covered by the previous speakers, but I just want to emphasize in the department or to beg them to make sure that they are looking after the rural areas. I want to make an example. The rural areas is so vast, and when we went to do oversight, what we observed, they have also a challenge of the transport because of the vastness of the areas that they are staying at. If they can at least twice a week make sure that there are healthcare workers who are going to these farms and mobile clinics that is attending to them at least twice a week than going there once a month. That's what now I want to ask the department to do, and I really welcome their effort and willingness of working with the community. Hopeful that they will not deliver the lip services. They will do the right thing to save our people. Thank you very much. I'm covered by the most of the speakers. Thank you very much.
Thank you, Member. Are there any more questions here in the chamber? Member Windvogel.
Thank you, Chair. I'm not clear in terms of the signing off. If Doctor can explain that to me. It's just a follow-up. And then the last concern, I will rather call it a concern. We as a department, if it's national, provincial, we like to emphasize the importance of healthcare workers. But when it comes to the point where we need to value, to put money to the service, then we have a problem. So we really want us, I think we really need to change our thinking because it was always my view that we need to absorb the healthcare workers so that they also have at least a stable income. They are protected, you know. That's why I'm saying it's so close to my heart. These healthcare workers, we praise them, we saying they are doing good, but when it comes to give them what they deserve, then we have all the other explanations. If we look at how you bring in cleaners into the department, what is wrong with bringing in the healthcare workers into the department? So that's my view. Just my view, Chair. We really need to look at that. Thank you, Chair.
Thank you, Member Windvogel. Dr. Karim, please.
Chair, yes, no. So I just wasn't able to connect now, but there's a slide that I showed with the little green ticks. That's the timeline. So what's happened, where we're at the moment in terms of sign-off, the 20th of February was the application deadline. Obviously, that passed four days ago. And so at the moment, during February, we will adjudicate the applications that have come in. And then by the 1st of March, we will obviously then make sure we sign the contracts. The document I signed off, by the way, was the transitional care policy. It's one of the cornerstones of, it's like COPC, it's one of our cornerstones in terms of transitional care. So, and by transitional care is a range, by the way, this we mean the members who know the Brackengate facility that we opened during COVID. We've extended that, for example, into a transitional care facility. So people palliation or people who are not ill enough to be in hospital, but not well enough to be at home. They're kind of transitioning in between. And so that's a transitional care policy that I signed off. But in terms of the process, yeah, I mean, Dr. Furfer and the team will adjudicate this week. And then obviously by March, yeah, we want to conclude this process. So, and get the, and we do that every year. And the NPOs know well by now our timelines and our processes as well. Thank you, Honourable Chair.
Minister, I see your hand is up.
Yes, thanks, Chair. I also wanted to respond to Member Van Vogel about her concern. Indeed, it is concerning because we say that they are part of the health system, yet they are not necessarily the employees of the health system. And we as health, I'm not only talking about the provincial health, I'm talking about as a sector, health system South Africa. I think we did drop a ball at the beginning. Let me explain further. The issue is about, you have got so many different components of community health workers. Starting in the 80s, during the HIV/AIDS, during the HIV/AIDS, we used to get them mostly from the NGOs. Like I know that in the Western Cape, then there was like NGOs like Zibonele and all of those, and similar in also other provinces. So they were part of the HIV/AIDS counselors and the others. Others used to be part of the going to do the outreaches as part of the HIV/AIDS. And then they ended up being absorbed, not absorbed as absorbed, but they work within the clinics where others will do the education at the outpatients, where the others will continue with the counseling. So we've got that group that are still within the system. And then now we've got others who have been part of the home-based care, which is you'll give them a slip to go and visit and check a mother has given birth in the hospital. Now just check whether they're breastfeeding and also check for the postnatal. It's another group. And then we've got another group where they'll be placed in the old age homes when you have those old age homes are jointly registered as a license by also Department of Social Development. For example, for those with a mental health, like a dementia, Alzheimer, and also maybe they've got cancers. That's another group. So the issue is about you have got the different components. Some of them, they might have education up to standard 2. Some of them, actually, they've been to 2 or 3 years at the university, but they were doing different kind of things. So now I was sitting in a situation because when a health worker, in terms of our constitution or a National Health Act, there's a definition of what is a health professional. It makes it difficult now that you'll be starting getting which ones and what will be the packaging of the delivery, and also what will be also the issues of the remuneration and so forth. So it's because we are sitting with all of these legacy of them. Hence, it makes it difficult. Hence, now each province, like for example, for us, we do a training, even us, province, not only from the NPOs, some of them, because there was an argument that it must start from when we have matric. And then it was about, but the majority of them, they don't have matric. And then lastly, for example, KZN, which is known as the flagship of community health workers. And it was, I had some projects there when I was also a student, postgrad students there. They've got what we call the Sukuma Sake. They've got a whole of the other additionals, which we call them TBAs, traditional birth attendants, who used to conduct deliveries, actually, in some of the areas like Hlabisa and so forth. So we have got the whole components of as many. In Limpopo, we have got even the traditional ones, which is, they are supposed to be actually observed as part of a traditional health practitioners, whatever act. So it's a whole complex. So everyone runs away from it and all of those. So when it was now said back to the Department of Labor, actually gave us a relief because we haven't come up with any kind of a solution going towards that. Yet we appreciate them, especially now during COVID. They did the community screening themselves, actually, without even having proper PPEs in some of the other areas, except the boots and whatever. They did also, even with the vaccination, they're still doing in terms of mobilizing the communities for the vaccination. And we're adding more layers like the mental health and all of those, which initially they were not even part of those, and we'll be adding more layers for violence prevention and so forth. I concur with you that we as a health system, we haven't done much justice on the community health workers as part of the health system as a sector in South Africa. So I do concur with you. But I think, as I said to my colleagues, that when we started 5 years ago, we have a summit, a workshop here in the Western Cape. We made it clear that we will be able to make sure at least whatever we do, there's an evidence, and also are supportive, journeying with them. Like I think the question from member from the EFF was talking about how, at what extent that you even help them, because some of these NPOs, they might have been anti-SARS NPOs. They will not know about the tax issues and all of those. Yet they've been doing the work for a long time, like in the palliative care. Palliative care actually is mostly done by the NPOs through their community health workers. So they are helping us. So indeed, I just hope that as a health sector, this needs to be resolved before even the next term that some other people take over. Because some of us, it's not only that we've been doing it now as politicians, it has been part of our work throughout in many provinces, but we have failed them. Thank you very much.
Sorry, thank you for that, Minister, for that background and context. It's much appreciated. Dr. Karim, do you wish to add anything?
No, Honourable Chair, just Member Baka Force's comment about the rural areas noted. I mean, we also agree that there's a particular challenge. Member Fry also wants to comment it, but nothing to add, Chair.
Thank you very much, Dr. Karim. Thank you very much, Minister. Members, if there are no further questions from your side, I wish to propose that we take a break before we come back and then give the members of the public who are with us the opportunity to pose questions. So it's now 10:15. Sorry, let's reconvene. Let's go for something to drink, a snack, and let's be back here at not a minute later than 25 to. That's 20 minutes from now, 25 to 11 that will be. Thank you very much. Members, I think it's only fair to the members online that we start. If you could please take your seats. Sorry, Doctor. You're sorting out. That's good. That's good. Members, welcome back, and also welcome back to the members of the public. Just a last check. Are there any further questions from the members? If you would feel to do so, thank you very much, Member Plato. We will wait. Member Brunkhuis?
Yes, thank you very much, Chairperson. Chairperson, myself and Member Plato, we were just discussing this issue that has appeared on the news for the last 1 or 2 days in terms of the cholera outbreak that was detected in the Gauteng province. If it's possible, if the department could maybe just give us a slight brief on how, I know it's not in the Western Cape, but if, for the benefit of the Western Cape citizens, how worried should we be, and what is the measures put in place in terms of that illness not spreading to the Western Cape? How well are we prepared to face a cholera situation? Thank you very much, Chair.
Thank you, Member Brunkhuis. Minister, I hope you heard that question. Do you wish to respond, or should Dr. Karim respond?
The department can respond. Thanks.
Dr. Karim?
Thank you. Thank you, Honourable Chair. So, Member Brunkhuis is quite right. I mean, at the moment, there's a cholera alert right throughout South Africa, and in fact, also in the sub-Saharan African region. I'm looking now, as we were talking about, some of the cross-border implications. So at the moment, it's Malawi, Mozambique, up north in South Africa, Gauteng, KZN, and Zimbabwe as well. So what we've done in the Western Cape to prepare ourselves, we've got a cholera alert. So all our healthcare workers right throughout the province are on the alert for cases of cholera. And we also have a provincial approach to cholera, should we pick up cholera, obviously in terms of containment or making sure that it doesn't spread, much like we did during COVID. So our local areas on the ground are on high alert for cholera at the moment, as much as we are with measles. Members of the House would know that we had the Cape Metro is currently being declared as a measles outbreak. So it's part of our surveillance that we've discussed in the legislature before, that we've had prior to COVID, accelerated during COVID, and now we're continuing. So we remain in the province on high alert for cholera, for measles, for pertussis, for a range of other infectious diseases that are actually quite pertinent. Post-COVID, we found that obviously those services have been displaced. Vaccinations are lower than they were because of COVID, and that's led to a resurgence of measles, of pertussis cases. But members, right, we're on a high alert for cholera in the Western Cape, and we will remain so. Thank you, Chair.
Thank you very much, Dr. Karim. We will now proceed to questions by the members of the public. When you put your question, please state your name clearly and speak into the mic. And we will take three questions at a time. So let's start from my left again. If you wish to raise a question, please put up your hand and we'll proceed from there. Thank you very much. See 3 hands so far. Can we start with the Imam, please? 4 hands. Imam.
My name is Tawfiq Eli. As we know, as I mentioned before, that I'm from the Mitchells Plain area. And thank you for the presentation, Dr. Karim, and for the members for inviting us today at this event. It's not entirely related to the discussion that was previously had, but one issue within the Muslim community in Mitchells Plain is the circumcision. So currently in the Muslim community, circumcision normally it takes place at a very young age in the Western Cape. So I know that the Western Cape government has made possible free circumcision for males between the age of 15. But we find that many, we can say Muslim households, they would rather prefer performing the circumcision at a younger age. However, this has meant that because it's private, they have to go the private avenue. It has made it a bit expensive for the Muslim community. I think it stands about 1,000 rand per circumcision, and especially in Mitchell's Plain, I've been inundated with calls to provide affordable circumcision for our communities. So that is one of the concerns that the Muslim community has. It is free, but it is, as we know, the Muslim community, they normally prefer to perform the circumcision at a younger age. Thank you.
Thank you, Imam. There were some hands over here. There are 4 hands on this side. There's another hand there. I'm first going to take the first two, the gentleman and the lady, and then we will ask Dr. Karim to respond before we take the following questions. The gentleman over there, please.
Thank you so much. My name is Dabuho Denyane. And so my question is in relation to what the latter speaker was asking in relation to the absorbment of CHWs in communities. Is that firstly, the Western Cape Health Department says we aspire to become a health system that is people-centric, trusted, and equitable. That's the equitable part, and that's the equity part and the people-centric approach that we're talking about when we're asking that CHWs must be involved, must be absorbed by the department. Secondly, it's in relation to what the latter speaker was speaking about when she was responding to the question of the member in the House today, is that they did the labor, then it's very difficult for labor to do this and that and that. But yet when calls for proposals are coming out, a job description is very clear to what a CHWU must do in order for them to do their palliative care working and whatever they're doing in the communities. So we find that approach and that answer a two-faced type of an answer to say, you did this with the labor, but when you call for proposals, you have a JD that you want them to do this, but then at the end of the day, you say you can't absorb them yet. There's a JD that controls what they must be doing on a day-to-day basis. So my question is, when are we really going to be people-centric and equitable to CHWs? Because a vast majority of the work that is done in communities, especially in primary healthcare, is done by our CHWs. And if it's done by our CHWs, they are assisting PHC nurses at hospitals and in clinics and in day hospitals to say, instead of you cleaning a wound, give it to us, we'll clean the wound for you so that you're able to care for the next patient. So we really need to understand, why is the department backtracking on them saying that people-centric, trusted, and equitable? We are speaking about that equitable share. We are speaking about that people-centric approach, but they can't be trusted themselves as the department. So the latter speaker, when doctor answers from the department's approach or the honorable minister, when they answer the question is, when is this going to be done? Because this backtracking is not going to help us. And even the minister of the finance minister, when he was speaking, there's a large chunk that went to health again. When are we going to be people-centric and equitable? Thank you.
Thank you. The lady next to the gentleman, please.
Good morning. My name is Amelia Mfiki from Ubomi Betu. 2 questions. Firstly, topping up to this issue of absorbing and not absorbing. If the department is not absorbing the healthcare, the community health care workers, whatever language that I'm forgetting, the challenge is that we are giving the NPOs the autonomy to play around our people. The reality is, for quite some time, previous years, there are people that were not paid their salaries by the NPOs because of whatever reasons. I don't want to mention names. 2, yes, it's true that we've been having this discussion for quite some time. Some of us were part of the consultation with the province and national of the re-engineering of primary healthcare. That's how it was worded previously. Now we said that we need our people to be absorbed so that because the organizations are saying, if we are giving out our staff, meaning the CHWs, to be absorbed, what about the organization? And Now, this is the director and the founder of the organization worried about their own facility and their salaries, not looking at the actual work and how do you then pay the person who's actually doing the job. Now, I see this in favor of that conversation, supporting the organizations that want to keep the building for themselves and not looking at the quality and the payment of our people. Two, we know the time frame is saying between 2023 and 2026, councillors will be trained or whoever will be trained for this transition. But we know that the same timeline is saying on the 20th, it was the due date of the NPOs to submit the call for proposal. In that call for proposal, it was asking people to mention the language of the CHWs, not councillors. Now, this again gives favor to those that have been working in this program to be a priority because some organizations do not have the CHWs, but they have councillors. And now, if you apply as an organization saying we have not been on this stage at the moment, because we don't want to lie to the department to say we have CHWs while we have councillors. Now, that's another thing. A key challenge that a question that I want to ask, in terms of the part of the priority areas are key population. And if you observe most of the organizations that have been working in our communities with the CHW program do not accommodate key pops. I'm saying do not because most of them. I'm saying they don't because we've worked with most of them and we know how they work with the communities. For example, in the applications that you guys have put out for a submission, I so wish you accommodated the young people and key pops in the sense of tracing because part of the program is linking them to care. But if you visit Amelia as young as 20 years in my home and you ask me about the clinic, I'll tell you, no, you are talking to the wrong person. Now, I so wish that we have plans to accommodate this program, particularly because the ratio is saying 1 to 60, right? Now, we know if you visit those people at their household, you won't find them. I so wish we have planned to accommodate them using the social media platform because that's where young people are and that's where you trace them with the actual names. I'm saying that because I'm part of the programs that work with key population and with clinical trials where we trace the people using the social media instead of visiting them at home because when you're there, you don't find them. Just the last point. Part of the reasons why we are not getting people on there, I'm worried about this ratio of 260 households or people to be reached. If you look at the number that we're looking at and the quality, we need to be strategic. We need to introduce the Procoli system or the finger scanning so that we can pick up when Amelia is using another ID of her sister in one of the facilities because your finger scanning cannot be wrong. So if we keep asking our people to visit this household, while we know that in our informal settlement, we change the address all the time, we will keep saying our people are failing. So with whatever that we are putting in place, we also need to contribute in making sure that their work is doable. Thank you.
Thank you very much for that. Members of the public, please allow me to say that this committee is very mindful of the fact that you do not often get the opportunity to engage with the department and this committee in this fashion. Nevertheless, I would request you to consider abbreviating your questions, if I may put it that way, in order to give as many members of the public the opportunity to put questions to the department. On that note, Dr. Karim, the Imam's question does not relate to the topic under discussion, so I'll leave it to your discretion whether you wish to respond to that or not. Thank you.
Yes, thanks, Honourable Chair. I mean, I can do very, very quickly respond because it's not quite the topic at hand, but I mean, I'll certainly take it back to the department in terms of the younger age of circumcision, so it's noted, Chair. The questions in about community health workers being absorbed into the department, as I mentioned in the conversation, in the presentation, that's obviously part of the bargaining chamber, bargaining council process. And there's part of the national process, and our HOD, Dr. Kloete, has been part of those conversations at National Department of Health, and our commitment was to await the outcome of the bargaining council process, and then obviously we will implement from there. That being said, we obviously will continue with the process that we've currently engaged upon, which is where we already are working via the NPOs to community health workers And that's process, the current process that we have will continue until the outcome of the bargaining council. I take the issue of the job description and controlling what happens in the from via the NPOs in terms of the outputs. But as I said, and that's why I've placed some emphasis on the priorities and strategies of the department, because we obviously want to make sure from a burden of disease that we're responding to the burden of disease via the NPOs and community health workers. And so that's quite important for us. And Dr. Furfrey mentioned what the process is about understanding localized geographic area needs. Dr. Furfrey can respond to each of the councillors. The priority areas and young people and the key pops. Absolutely. I mean, reaching young people has always been a challenge, even during COVID times. And we did find that using social media to reach young people is a lot more attractive to young people. And so I think that's quite right. I mean, point well taken about reaching young people via social media. We have other programs in the department, not necessarily part of this home and community-based care services, but we have funded other we funded NPOs, but via different sources of funding that focus on some of the other key POPs, particularly when it comes to HIV and TB services, and funding that we get from the Department of Health. But we've also got funding from some of the grantees like the USAID, etc. They're quite a large contributor via a government-to-government agreement between the Western Cape government and the United States government that Premier Windy had negotiated for us on our behalf. It's about, I think it's $10 million over 5 years. Something like that. So quite a large amount of money. And through that grant, we fund a number of NPOs to provide HIV services to young people and other key populations. Perhaps Dr. Furley wants to respond to each of counselling and the ratio as well.
So just in terms of the naming of the councillors, that's going to be changing. So as it was communicated at the briefing sessions, we are from the 1st of April no longer going to refer to lay councillors as lay councillors anymore. And this also aligns to the counselling strategy that we've recently developed within the department. Although the counselling experience will be acknowledged when we are looking at which NPOs can render the service that is needed in a particular geographic area. So there will all be lay councillors, but we are acknowledging that there will be there will all be CHWs, apologies, but we are acknowledging that there will be CHWs with lay councillor experience and CHWs with home and community-based care experience, with the intention that by the end of the 3 years, we will have a broader base of CHWs that have a broader skill set, whereas now there's specific skill set for different cadres. So we do acknowledge the experience, although the title, so the service won't change, the title will change, and then over a period of time, based on training, they would then it would all be balanced out, if that's the correct term, by the end of the 3 years. And what was the
Thank you, Doctor.
Yes, so that is what we have stated, but again, it depends on population density in a particular geographic area. So that is just an average, but each district or each geographic area is divided into nodes. They don't all have the same amount of nodes, but it's the way the districts are divided. So it really does differ from district to district or sub-district to sub-district, how those figures are worked out. It's not standardized. It depends on burden of disease in the area and population density.
Thank you very much. Minister, I see your hand is up. Do you wish to contribute?
Yes, just to add, I think the last part, just to make an example. Central Karoo might have fewer people, but if you look in terms of the distances that they have to travel, one ward, for example, would be in Nelsport. A part of the ward is actually also in the Beaufort West Central, or like Merville and Beaufort West Central, it's become something like that. So one has to consider that It's similar also with the other areas like the Matsekama and also the Witzenberg. But I also want to acknowledge that there are other community health workers where we find that we get a whole lot of help, specifically in the farming communities, from the farmers, which becomes actually even additional. But what I was, my hand was for, it was about, again, I have to take back to the members and also the community to where NHI is. Currently, they are testing, they are piloting what we call them CUPs, CUP, which is contracted units, primary care, probably primary care. I think Dr. Karim can help me there. What does it mean? As you know that with the NHI, it's about where government shouldn't be the monopoly in rendering services. Any other stakeholder, be it a private licensed health hospital or clinic or day hospital, GP, or even the NGOs and NPOs, if they could be able to demonstrate that they could be able to render the particular service as according to the specs that is being required, they could be able to do so. So the national department, using district systems again, if you remember, in the phase 1, there were 11 districts. There were supposed to be 9, and then other areas like in the Eastern Cape, they've added theirs. Ours, we're using Eden, which is the current garden route that they piloted. Some of these, what I've mentioned, some of these interventions for the NHI. So what I'm getting at is about currently, we are piloting in the Neisner Bito, and they are expanding, I think, in the Cederberg, I don't know which other areas, which is the National Department of Health trying to implement some of the other parts of strengthening primary health care, taking services away from the government to be able to be rendered by other parties. So when you say, absorb them. The health reforms where we're getting at actually contradicts that. They are saying that the government can do as much, and in the province we become a steward, whether if the service offered, if they say, for example, orthopedic care surgeries must go to Mediclinic, eye surgeries must go maybe to Netcare, and then palliative care must go to the districts and through the NPOs, the NGOs. That's how it's going to be. So now we cannot have this conversation, which actually now the train has left the station because the health reforms of South Africa actually say that we shouldn't be monopoly. We should be able, everyone else could be a service provider, which is in the Western Cape is being piloted in terms of these units that will be contracted to render the services on behalf of the government. As that's just what I wanted to indicate, Chair. Thank you.
Thank you, Minister. We will take the next round of questions from the public. If you could raise your hands again, please. I see the lady with the striped attire and the lady next to her in black and the lady behind the gentleman with the beard and the beret and the gentleman with the beard and the beret, and then we'll get to you. So there are 4 people who will ask questions now. First, the lady in the striped attire.
Good morning, everyone. My name is Noe Mdai from Kukuletu. I want to start with the last explanation that the Minister has given about in terms of NHI. You know, it's been said, I think one of my questions before she explained it was to go and ask about the processes, how far is this NHI? Because in the level of a community, in the level of grassroots, we really, this was introduced as a good thing for a community at large to render services. Now we need to know really how far is it. I'm hearing about the hubs and all that, but really, when we talk about services that must be rendered to community, those NHI processes mustn't be held. It must filter, go straight to the community so that we know where we are. because at the end of the day, we are talking about the right to health to a community. Then I want to go to, I will shorten my question. I want to go to the matter of SHWs. In terms of health and social issue, we really need to applaud our foot soldiers as SHWs. And it's a pain when West were hearing that they must do 200 and odd household per month. Imagine their safety. You understand? What's wrong to Western Cape, according to other provinces, to absorb we're all going to talk about absorbing, because we've been doing actions and action. We know why we're doing actions about Indo-UK workers. You understand? What's wrong to Western Cape if the other province can do it to get them direct to Department of Health? What is wrong with Western Cape that there must be a middleman? If they've been promised a long time, we know and we applaud them, the work that they even did in terms of COVID-19. They were the ones that risked their lives. You know, so why? Why now they must mention grade 10 and grade what? Meanwhile, when they are doing the work, even the officials are coming here and give the stats, how the good they are doing, who's doing all those dirty work. It's our CHWs. But why? Why now it must be an issue and they need to be absorbed to get direct what they deserve to the Department of Health? In terms of ideal clinic, I think that's the other thing we really need to look at in terms of render services of deliver health service that is good for our community. We need to check. I'm not going to dwell on other questions, but really when it was given the presentation about the care workers, really let's look at the matter of absorbing. Let's cut out this middleman. They're officials, they have to apply for jobs and what, but what about the people that are doing the work on the ground? Sure.
Thank you. The lady in black.
Good morning, everyone. Renee Ackerman from the IDEPA Manenberg cluster. As well as I'm a CHW in those areas, so I won't be touching on the CHW issues, but mostly on the needs of patients, especially in communities. Because I've read through the presentation, and as I can see, as the Healthcare 2030 states that the different services that will be rendered, like mental health, even those CHWs get referrals to go see that mental health patient, but where do they take it from there? The same goes for, we need to do the work in the communities, but we have a lack of supplies from health facilities. So where does that help where it comes to in decreasing injuries from patients or even just community members? The other thing is that rehabilitation. People that can't come to the facilities, rehabilitation is supposed to take place at home as well. That is where the RCWs come in, but most of the communities don't even see that service. One other thing also is patient transport. It's also outlined here, patient-centered, because we have a problem in communities as well. So all these little things that's in the Healthcare 2030 presentation and proposal, how is that going to happen? Because it's not happening now, and it has been mentioned on other occasions. So even the social services, where it states that, like the minister mentioned earlier, the MEC mentioned earlier on that, the catch and match. So as CHWs, we do that. So we go to patients, we fill that out. Now this lady has a 10-month-old baby. So I write down that, okay, social services need birth certificate. So from there, it goes to the professional nurse. From the professional nurse, where does it actually go to? So now 3 months later, I go back to do my follow-up visit on the baby. So I don't have any answers for the mom. So all these services is good and well. And I see most of it is with the NPOs. But at the end of the day, the CHWs does all this work. And at the end of the day, they need to be accountable to the patients. Because a lot of these things are exactly what is needed, but it doesn't get done. There was one more thing, but now, oh yes, as well as the COPC meetings. I know at facilities it's limited to who can sit in. As for NPOs, the different stakeholders and the NPOs, especially representing the CHWs, which is good and well, but most of the time it's management. Why isn't CHWs allowed to sit in there? Because they've got the personal experience of what's going on in the ground and how to actually convey it to the necessary people. So basically, yeah, that's most of the things that was my concern, the needs surrounding the patients. Oh, and where the CHWs is concerned, we look at all the needs that we need to render, but we don't see that the needs of the CHWs get seen to, because like the 1990 proposal is that to decrease infections for TB and HIV, but CHWs don't even get proper healthcare for themselves, where, for example, TB is airborne. So if a CHW goes to a TB-infested house, yes, you have your mask and stuff, but even in communities, we have difficulty in getting masks. So how's the CHW's health also protected with this 2030 patient care or health care? Okay, thank you. That's all I wanted to say.
Thank you. The lady in the white head attire.
Good morning, everybody. I'm Halima Isaacs. I'm from Menenberg, but I'm here for my organization. Renee has touched on everything that the things that I wanted to say, but the one thing that
Can I interrupt you? Could I ask the lady in black to please switch off her microphone?
Oh, sorry.
Thank you. Please proceed.
Sorry, guys.
Thank you.
I'm Halima Isaacs. I'm from Menenberg. I represent my organization, Menenberg People Center. Renee has touched on the questions that I wanted to ask, but there's just one question. Currently, we as an NGO, we support the NPO rendering a service in Menenberg. We have the CDU packaging that patients collect at our center, but currently we are not being paid a cent, and so does everybody else that renders that service in the community. NGOs, churches, they don't get any stipend or support from these NGOs. The NPO, we do it, we also struggling organizations, but I see they talk about payment within the new contract that is being given to the NPOs. So I would appreciate that if that can be made available, when it is, how much and how the payment should be made to the NGO supporting that NPO working within Menenberg. The presentation that Dr. Karim has presented, it looks good on paper. But is this reality? For us as communities on the ground, we need to fight the fight. And we need to support our community. So how is it would be appreciated if this can be a reality for us as communities. So I would just say thank you to everybody for having us here.
Thank you. The gentleman with the beret, please.
Good mornings, Chair, and all protocol observed. My name is Mike Hofmeester. I am the Secretary of the Busheblijvers Development Forum. I'm also the Chairperson of the Busheblijvers Community Health Clinic. Dr. Karim and others, we do welcome the presentation, and we are very impressed with certain issues, and some issues we are a bit concerned because it's not clear to us or to myself. I also appreciate that the focus is on health and wellness. But if I go to, it's just a bit of a problem that this presentation hasn't numbers, it's not marked, so I don't know which page to say. But I will refer you to the package of care, wellness services, where it states comprehensive packages of care providing the living, learning, social working space department will strive to promote wellness through the expanding of the current service and the establishment of wellness hubs. Now, the department is saying the establishment of wellness hubs. Now, currently, we in Bushablavers has established some wellness hubs. Sister Langley is from the NGO Caring Networks, is with me, we work together. The issue about the lack of infrastructure within our areas. Now, if the department wants to expand the wellness hubs where there's not enough infrastructure, there are not enough buildings for that service to be provided. But be it as it may, Chair, the facilities that are there, it belongs to the city of Cape Town. Now we fall under province. Now for us to make use of a city of Cape Town's venue, the first thing they tell you, no, you need to pay. Second thing you need to tell, they tell you, no, you cannot have it. Then we engage with the various councillors of that department from Ward 24. Then we ask them, can you arrange that we are from province? Can we use that structure like the hall in the west, the community center in Nooitgedag, the sports field in Bushablavers? Then there's a fee to attach. Now we know that councils can apply for a free usage, etc. But with due respect, Chairperson, you know, we approached the councillors, the 3 councillors. You now name them: Councillor Iso, Councillor Teresa, Councillor Nansiga of Ward 22. They don't respond. Now, when the community go to the various venues, they are told, because I was there personally when they told us, the caretaker, you cannot use that, you know. You need to go and make an appointment, etc. So that is my one concern about the wellness services. Then the other point here is that it's also, can't say the number, but community health workers, CHWs. Now this point has been debated and discussed, you know, and the absorption, etc., etc. But one of the concerns, it was also highlighted about the safety and whether CHWs are working in very high risk areas. You know, we do get students from Stellenbosch, where the NGO need to take them into the area, but the problem about their safety is of the utmost importance. You know, that is the one. And my concern on that, on the CSW chairperson, where you are saying in the discussion was that it's, you know, absorbed and the bargaining council, waiting for the outcome of the bargaining council. Now, I need to say, Chair, it can't hang in the air saying we're waiting for the outcome of the bargaining council. We need to be specific, because some issues here, it's specific 1st of March, this date. And I would like to, you know, be specific on the bargaining council. Get the date of the bargaining council, because it is important for those people that are working on the ground, Chair. Then also, Chairperson, the sectorial determination. Where is it? But I will just highlight it, Chair, because it's here. I just marked it. It's also, Chair, when, you see, we can't have something where we sit here and say, I can go back and say, you know, the sectorial, waiting for the outcome of sectorial thingy, when. That is that one, Chair. And did I cover everything? Oh, yeah, this is my last one. That is the last page of this presentation. I like this. Really, I like this. MPOs are linked closely with the people in the community and can provide valuable insight when designing and delivering much needed services. It's very interesting. I would like to know how come that is that. Because why I'm saying this, Chair, I don't think it's only the MPOs that can do that. You know, you do have the health committee members who's working on the floor. So I would like to say that there are also other organizations that can be also assist in providing the necessary services, because they know the needs and the priorities of that area. Chair, on that note, I will pause And I will say thank you very much for the opportunity, and I will report back. Thank you, Chair.
Thank you. Dr. Karim.
Chair, I'm not sure if Minister wants, or Minister's
Yeah,
gone.
yeah.
Oh,
Yeah.
she's
No, I'm here. Can I just respond on one at the NHI, and also again, I just want to respond about the absorption, and then the rest Dr. Karim can continue. The NHI is a national legislation which currently is still within the national parliament. But because the implementation will involve the provinces, as it was previous with the public hearings, there will be public hearings. Once they are done with it at the National Council of Provinces, it's going to go to the legislatures. And then there will be another round of the public hearings, which will be driven by the MPs, which is this committee here, going to different places. So it's out of our hands. In what I was trying to highlight is that the government side, which is the National Department of Health, they are still, as they did from 2012, in piloting some of the interventions. They still continuing, irrespective that where the bill is. So what I was saying is about part of the NHI, they are talking about where in the district, in the communities, there should be also other service providers. It could be private health, it could be the NPOs, it could be anywhere. And for us, who are part of those who are piloting that aspect of these contracted units in the NISNA and the PITO, and will be expanding it. So it's part of government. This committee will be able to send to everyone when now they've got the bill that needs to be to do the public hearings as part of the national parliament system. So that is that part of NHI. So it's not within us as this department to be able to assist in that regard, but we are doing what government is doing, the piloting of the contracting units for the primary care. The second part of it about the absorption, I did indicate, I acknowledge that as a health sector in South Africa as a whole, we did actually mess up in regard to not taking further the promises within the white papers and everything. Actually, even the whole district health system model. We are lucky that in the Western Cape, we are still even using the sub-district. Actually, we strengthened a sub-district, which is using the municipality boundaries, the municipality boundaries in that regard, because they are different. You cannot treat Matsikama same way that we treat Saldanha, although they are all, for example, in the Vescas district. So what I'm trying to highlight is about it ended up when there was an announcement after the specifically now 2018, which is the Bargaining Council resolution of the wage. And then it was about the language, whether they to absorb or not. Even the National Health Department, they omitted, or probably to the whole of us, the fourth National Health Council, not to look deeply in regard to these components that Umama Amila was talking about, because there are counselors, not community health workers, who started as like they are doing community health workers function during the HIV/AIDS, and they are still within us, yet there's, in our health facilities, but they're still not even employed. In the early 80s, there are people who have been working and they are here in the early 80s. Where do they belong? Because they are still not part of the government, but they're still being treated as such. Some of them might be absorbed, I'm putting inverted commas. So what happened now with the provinces? I made an example that then they did the absorption, but putting under the PESAL, inverted commas, the AP, which is the abnormal absorption, because they cannot, because within the PESAL, you have to meet such kind of the requirements when it comes to the human resource for health in regard to these, to all other categories. I made an example in terms of what happened in Mpumalanga and also in KZN, when it ended up depicting as if that you are covered when you look in terms of the bigger picture. Yet you'll find that some of the others, when you say human resource for health, when you say 75%, and then you think it's bloated, only to find that it's because they added health workers as part of it, yet our system doesn't accommodate as such. There are only people who are health professionals. There's a healthcare worker, which could be anyone, everyone who's working in the health space, even the administrator. But a health professional, it has got its own definition, which now, going back to the drawing board, that's when we realized actually even the 2010, the service delivery engineering primary care that we envisaged, you couldn't be able to apply because the issue of the entry in terms of who is a community health worker, it came up with so many definitions and at what level. Remember, it's the system that wants us to do that. It's not that I am a health professional. I understand all the dynamics of leaving other health workers behind because we are all part of the same system trying to solve one problem. And we need each other. You cannot only use a left hand, you need a right hand, you need a left leg and whatever, all of those. So that's when now it went back to that actually what you're supposed to do, they shouldn't be actually what you wanted to do, as you probably wanted to transplant what happened, for example, in the Brazil, which also actually we were even sent to Thailand for the whole provinces. We've been even sent there. In South Africa, you cannot be able to do as such. You cannot, first of all, you need to adopt the principle. That's when I made an example of community-oriented primary care, going back to the basics of the 1940. You must adopt. There, it clearly states that there should be the NGOs, community-based organizations, faith-based organizations, everyone in that particular local area should be involved because that's what primary care is all about. It cannot be delivered by government alone, but the government should be a steward so that to coordinate all what is happening, whether it's done by the GP, which is a private, whether it's done by Anti-SARA's, NPO, and whatever. So COPC as a principle of rendering primary care, which is community health workers form part of, it is a must that you don't leave the NPOs, GP, whatever behind. Now, in issue of, in terms of the absorption, what we are saying is about now, it has gone back to the drawing board, to the Department of Labor, where they could be able to make a determination that they will give to the national health sector and the way forward in regard to that. But one thing that we haven't compromised is non-negotiable. No one will be getting a salary that is below as accordingly in terms of the bargaining council. How we manage it in the province, it's about where it's part of the specs. It is a must that there must be a PN, a professional nurse, because we are using the data as well. Professional nurse has to oversee so that what is supposed to be delivered as according to our mandate needs to be delivered. And also they need to form part of the health system and attach to a clinic or CSDC or whatever, so that the whole thing of one patient, because we're talking about one patient. So it's not about patients of community workers and whatever, and also for the referral pathway. So that's what we are doing. Yes, of course, I agree with you. There will be elements of where an NPO will want to survive through government tenders. So it might not necessarily be about that. They might, the motive was about to do good, probably, but it's about that. They treat it as a business, whereas from where we are sitting, health is not a commodity, it's a human rights issue. But the team has just indicated that how do they ensure that these NGOs and NPOs deliver as they're supposed to deliver. And lastly, from my side, we are still due to have a 5-year review because we had the summit then in terms of going forward, but it was put on pause because we are waiting for the outcome from the labor and also from the bargaining council chambers, all that. But generally, the issue is about we've got different categories. Even those who are calling them councillors, the umbrella body, somehow they are being also added as part of the council. That's why there was a thing, I think, Amelia, you are familiar with that. There was one time a circular that says everyone now must go, those councillors must go back to the communities and do the HIV testing there. And then there was an outcry that, ever since we started, we have always been working the facilities, because the community health worker must be in the community, not in the kind of. So I agree with you that ideally they were supposed to have done, who should have done something to absorb them. Now, with other provinces, they've put on pause because the whole thing now has become biting some of them. So we cannot go back now and do the mistake that the other province did, even if it was for the benefit of the Commonwealth workers. It means that there were times where the laws were breached. So that's where we are currently. Thank you, Dr. Karim.
Thank you, Minister, for that context. It's very useful. Dr. Karim.
Thank you, Chair. Thank you, Minister. So maybe just to add to Minister's comments, so certainly in terms of the way we obviously determine the needs of the communities, and the whole intention is to work with the communities in determining those needs. But we also have quite a lot of data from our data center about the burden of disease in each of the geographic areas. So we'll know, for example, what the burden of mental health presentations are, what the burden of child health issues are, or immunization needs are. So we obviously combine those processes in assessing the needs of the communities, and therefore the call for proposals, and as Dr. Furfure explained, in terms of responding to the needs of the communities around, and that's how we do it. The colleagues from the Manenberg People Center acknowledged the points made about not being paid as a people center, about the NPOs surrounding using the people center being paid. I was in contact with the substructure office while the colleagues were asking the question, and they're inviting you to make contact with them so they can have a conversation about that, because the contract is not with the Manenberg People Center, as you've noted. So the substructure office can deal specifically with that. There was an issue about, I think the date, as Minister was saying, the date that it's in the presentation by which the process of the absorption and the bargaining council would be concluded is 31st of March 2025. So that's a line in the sand by which the national process was meant to be concluded, and obviously we'll be awaiting, I'm keenly awaiting the outcome of that, as Minister was saying. And we acknowledge the point that it's not just NPOs in the communities, but there are structures like the health committees. This wasn't the focus of this morning, but we work very closely with the health committees. In fact, Minister, probably one of the ministers who over the 8 years has been probably to all of the health committees and all of the communities. So we acknowledge that the health committees certainly do have a wealth of expertise that we can draw upon in determining the needs of the communities, and we certainly acknowledge that from a department side as well. Anything else? The issue around COPC and joining that conversation, absolutely. We are busy embarking on a process now from the department side of talking through our Indaba processes, as we call it, with consulting our strategy with a whole range of stakeholders, and COPC is certainly a central tenet of that consultation process and that strategy. We're having an internal Indaba in fact, in a week's time, where we will have a conversation with our sub-district managers, and part of that conversation is COPC and how communities can join that conversation and how communities can provide input into the process around COPC. Anything else? I think, Chair, yeah.
Thank you, Dr. Karim. The lady over here had a question. Are there any other questions? The gentleman in the green, and the lady again, and that lady. So this lady first, please.
Is it still morning? All right. This is Nelly Swangwali from the Treatment Action Campaign. One, I think for me, I have 3 questions, maybe, and a comment. I think by this time we're going to talk another language, is to say the CHWs were already absorbed by the department. I remember when we had the consultation where the department adopted the Brazilian model to say that's the good model that the government can use in terms of absorbing the CHWs. And that Brazilian model had also came up with the issues of how much money do these comrades must get, each person as CHWs. But my worry is that when these people do the voluntary work, there is no criteria. There is no consultation. There is no selection. There is no issue of education. They are doing their job. But now, because they have to get some allowances Now there's an issue of criteria. That worries me a lot. 2, the National Department is clear up when we talk about CHWs. The package is talking about 4,000 rand each person. But the exploitation that these comrades are getting from these NPOs, when they employ them, they are just giving them far less than that amount. I can give an example for one of the NGOs that is well known. When they give the CHWs money, they only give them 2,000 rand, 800 rand. And on that 200, 800 rand, there is also issue of a uniform, which the National Department is stating clear that each CHW must have 700 rand for the uniform. But when you go to these NGOs that are employing them, they only gave them 400 rand with no leave, which is on the package of the National Department. It's clear that they are also allowed to have 21 days of leave. So this department, actually, the CHWs are already exploited by NPOs. I don't know why the department, particularly the Western Cape, didn't want to absorb them. We have a culture in the Western Cape of doing what we want, not other provinces do. We don't want even to copy what provinces are doing, right? Because Tina, we want to do our own thing, which is a problem. Because at the end of the day, we have people that are doing the job, that are being underpaid by the NPOs. 3, one of the questions that I would like to know, Amelia, when you talk about CHWs or home-based carers, in 2 government hospitals that I know, Tygerberg, Wynberg, they already absorbed home-based carers on the trolley room and on the EC room, meaning the trauma units. Their job is to escort patients to the bathrooms and to wash patients. So it's easing the burden of work from ENAs and staff nurses. So the home-based carers are doing that job. But in Khayelitsha, none of the home-based carers are working there. The trolley room in Khayelitsha is having 29 beds. But when you count that 29 beds according to the ratio of the staff members, it's embarrassment. Now, I just wanted to check into about what is the criteria in terms of selecting the home-based carers that are going to be absorbed in hospitals, and what is the criteria of selecting the hospitals? Lastly, these community care workers, they are working under very bad circumstances. They don't have phones. They have to track the patients. If you want to track the patients that are remaining in care, you need to have cell phones. They don't have cell phones. Even the uniform is old. They don't have security. They are being robbed every day. They are relying on the community and on the communities and also on the neighborhood watch, which is even those people are unarmed. They don't have land guns, but they are working. When you talk about that, these people have to take treatment from the facility to the community with their bags. There are no cars that are allocated to assist them. So, and this document doesn't say anything about that. And I'm worried about this document also. I think towards the end of last year or last of last year, we were called by the department in the, what is that hotel next to the CTICC. They were presenting a good plan that speaks to integrate the community care workers with CCMT's program. And on their presentation, we adopted it as civil society forum and other NGOs that were there. But up until today, they were saying we are going to wait for the consultation and then we will come back. Up until today, we don't have any feedback. I'm worried about these good implementing plans without implementation. I'm worried about that. We will come out every day having these good books, but dololo implementation. And no one, if we need accountability, we cannot find anyone. So my worry is that, can we please get the time frame as to say who is going to be responsible for the absorption, when, how, what is the ratio? Because at the end of the day, we are supporting these people, comrades. Some of them, they have kids that are at the university level. They can't even pay their school fees, but they are working for 20 years. I thank you.
Thank you. The gentleman with the green shirt.
Good morning, everybody. I'm Leslie Sylvester from the Heideveld cluster. First of all, I'm very concerned about the CHW workers. Who is trained and who is not trained, that render the service of the community, that don't belong to a community, that don't belong to a NPO. And the number two, how and where do we fit in, or they fit in this package of care? What I would like to see, that going forward, that service for our community is done to the perfectionists. And what I would also like to see, that the government department must take charge of those platforms of NGOs and all that, and make sure that things is happening, because at this point in time, it's a can of worms, and nothing is happening. I do thank you.
Thank you. The lady who previously asked the question.
My question is just to add to the one of the NPOs that is not paying the NGOs that is giving them space. It's not only the Manenberg People's Center, it's other organizations in the community as well, like the churches and other venues. So, Dr. Karim, I would like to know, can we invite those that is also rendering that service to the meeting with, if we set up a meeting with substructure regarding that? The other thing is that the patients that needs in-care patient at home and is not able to go to hospital, they're not that sick to get inpatient care, but they're at home. So how do we access the doctors to come out to the house to assess the patient? Because like the previous speakers have said about the health net transport that has been discontinued at the day hospital level, like Grootskies and the Tygerbergs and Somersets, they are the hospitals that gets the health net. But the day hospital no longer has the health net. So those patients has no access because there's no transport to take them to the hospital to see a doctor. So that's the other problem that we have within our community. CHW is struggling to get the necessary transport for those patients to hospital to see a doctor. Thank you.
Thank you. The lady to my left.
Good morning, everybody. I'm Deirdre Kulait from Touch Community Services. All I want to know is in the demarcation and the service notes that carers are working in, how do they determine how many carers must work in a service note where communities that flares up at evening time, informal settlements, buildings that flares up, and many times the carers that are given per note that need to work in that area are too little. I just would like to know. Thank you.
Thank you. The lady on my right with the striped attire.
Um, just the intervention in terms of rendering services. When you check and look at Kukuletu Clinic, I'm a chairperson of Kukuletu Clinic. That clusters with other 3 city clinics. We need an intervention in terms of rendering services, utilizing our halls that are under UCIT. We find it difficult to, if you look at this week on Monday, we have all the facilities in subtraction, which is plain giving the report how they work and all that. But when you check the stats in terms of our people that are defaulting, and check our facilities that we're using. That's why we have to utilize our halls that are near whatever patients to go and fetch their medication. But the intervention that I'm asking from each department is that we find it very difficult to use our halls in terms of a community go fetch medication in the house. Can it be something that must be done? Because we cannot pay using our own halls that were built in terms of what we need in our areas. Now halls are there, we cannot, even if you check in terms of a crime, youth cannot even use those halls. Now, if we ask, myself and my facility manager went to Fezeka and go ask, because we had a contract last time when we have Mr. Makamba, other manager that is not there anymore. But now we find it very difficult. We must sign a contract, we must send to pillar to post. Why? That is for the need, that is for the community, the benefit of the community, when checking people that are defaulting. When you check a clinic, we still even yesterday have a mass meeting talking about building of a new hospital in Kukuletu. That hospital was there before I was even born, 1964. Now, when you ask to utilize also that you can access service to render services to community, you find it difficult to use the community hall. Why it calls community hall? We cannot utilize them.
Thank you. Minister, I've noted that your devices are low on battery. Do you wish to respond?
Yes, I'm still here. I think it's 5%.
Thank you. Please proceed.
Yes, I'll just respond, Chair, I'll just again on one question so that we can have the clarity way forward, because indicated that wants to have time frames when and all of those. I think I don't want to go back what I've said earlier. I don't want to repeat, but the take home is about the process of doing anything related to community health workers by the province has been put on pause whilst the National Health Department is engaging with the Department of Labour in regard on the way forward. So for all other interventions where they've been absorbed, they've been whatever, they are still under NPO and all of those. So that conversation, it has been put on hold. It doesn't stop this committee, if they want to call the National Department to present in terms of that, what is the time frame, when will this be finalized, and all of those, that it can be done, because that is the national imperative in regard to that part of it. So we won't be able to respond around that. And we cannot, as a province, now going back to what was said, that now the process has to be put on hold. As I indicated earlier, for us, we took the road of working with the civil society as per the realization of the principles of primary health care that requires multi-sectoral collaboration and everything else. Now, the second part, the last part, taking note that the National Department, which is busy with the piloting of some components of the NHI, which is everyone has been asking when will that be implemented. Part of it is about using the piloting contracting units, primary care packages, which will be mostly done by the same NPOs, NGOs, which is I did indicate that for us, already in the nice Nabito substructure, and now it's going to be extended, I think, to Cederberg or whatever, which we are doing for the national. Therefore, now when we're going to ask the department, the National Health, that whether we're going to absorb the directive to absorb this, they will, of course, quote the issue of the labor issues related, which is being addressed by the Department of Labor and Employment, and also about their NHI implementation aspect, which is they are saying they are contracting these same NPOs that we say they shouldn't render the services and so forth. So there's that kind of a part. So as a province going forward, that question, when you're going to absorb them, we are waiting in regard to the processes that now has been put on hold by the national in regard to the whole aspect of the CHWs, except on the issues of the resolution, one part of the 2018 Bargaining Council in regards to the salaries. Thank you, Chair. Dr. Karim?
Thank you, Minister. Dr. Karim.
Thank you, Minister. Thank you, Chair. So just a couple of additions. The issue of the implementation plans, the issue of the community service prioritization, and just to deal with that. Obviously, the implementation plans are done at the local level, at the substructure level, and the key, I would suggest for the NPOs, that the key officers, obviously, and the contact points are the substructure officers, because that's where the localized implementation happens. And I would certainly support that you invite other people from the MPC team, that you can invite other people to join that meeting. I mean, I think that would be, the whole point is to consult with communities, whoever you feel would be appropriate for that meeting, and that's where the local implementation happens. I will pick up the issue of inpatient care at home and getting staff to go out to patients in the home. The system of community health work is in fact designed to do that. So a community health worker should assess the patient, and then obviously there's a referral form, and they bring, if the patient is required to go back into the hospital or into the primary care facility. That's the system, because it will be very difficult to get the medical staff, doctors out from the clinic to the community. I mean, we just won't have enough staff to be able to do that. But the community health worker system that we've put into place is designed to, in fact, do that. I'm just confirming with Dr. Furfrey about the minimum wage and the implementation of that. Absolutely. From the 1st of March, but most of our workers already are paid above the minimum wage, and we'd agreed, obviously, we're not going to drop anybody's salaries. Demarcating the issue around service nodes, that was what Dr. Furfrey also explained about being able to localize what the geographic needs are inside that service node, and that will be the work of the substructure team, and I will take that work back to the team, to the substructure team. Was anything else that I wanted to... Yeah, I think there was an issue, I think Mr. Sylvester raised about community health workers not belonging to NPOs. I take note of that comment. I mean, there are some community health workers or community organizations that are not necessarily part of the NPOs that we put the calls out for proposals. And that's certainly part of the conversation that we'll take back into the department, Mr. Sylvester, because I do note that, and I mean, it has come up before from other communities as well. Because not everybody's organized into an NPO neatly, and when we put a call for proposals, it normally goes to that group of people. So I think that's a point well taken, and yeah, we know Mr. Sylvester well. We meet each other at other venues as well, where the first Thursdays where Mr. Sylvester makes similar points. Honourable Chair, I think that's probably it.
Thank you very much, Doctor. Members of the public, can we do a last round of questions? The lady who raised her hand.
I just want to know, on the service description, I know the screening and referrals get done, because like I said, I'm a CHW myself, and between myself and my partner, we have like about 400 households between us. But my main question on that is that, why doesn't CHWs get supplied with equipment like blood pressure, the mobile blood pressure machines, or even diabetic machines? Because someone said earlier that sometimes it's very hard to get the patient to the hospital or even get the service to the patient. But seeing that CHWs is on the ground every day, why not equip them to do blood pressures? Because when you do households, people will say, no, I don't have any ailments, but sometimes people don't even know they may be suffering from high blood. But every 6 weeks, if you do need to go back to your household, that you follow up. If CHWs is equipped with this kind of stuff, then it means people can be checked regularly, and so certain illnesses and ailments can be actually treated. So I'm just bringing that up. Why can't CHWs be equipped with that? And as well as we always have a decrease of supplies for wound care. So that also, because people's wound doesn't even get done because there's never enough supplies. So yeah, just that my main thing is that CHWs need to be equipped for the work in order for patients to get proper health care in communities. Thank you.
Thank you. Gentleman over there.
Thank you so much. I think before the contract signing of the NPOs, I think it needs to be emphasized to the very same NPOs to say it is very important when they do follow up, when they're tracing unconfirmed loss, to follow-ups and follow-ups in the healthcare system and them linking back to services. It's very important that they follow that process thorough. And in the MDT meetings, it needs also to be emphasized that should they not attend such meetings, whereby they'll be discussing such patient conditions and those unconfirmed loss to follow-ups, either TB, HIV, cancer, whatever services that they need to be followed up on, that NPO must be held accountable, because it is high time that NPO have been running around doing whatever they're supposed to be doing and not doing what they were supposed to be doing. So it needs to be emphasized even before contract signing to say, as part of you signing this contract, you are also liable to do 1, 2, 3, 4, and 5. Because as part of the COPC package, yes, it's there, but those things were not explicit in how those modalities need to be done in that fashion. Because it is very important that those NPOs who are attending those COPC meetings and MDT meetings form part of those decisions and be able to implement those back into the ground, because it's very disappointing. You find a care worker on the road. They were tracing, for example, Mamfusi in an informal settlement in Tebogo village, and now they only went twice or thrice. They'll assume, say, I've knocked, there was no answer, but there was no other modality that was used to try and trace that very same patient. We know our patients don't like giving the right addresses and right cell phone numbers, but there is modalities for us to trace those patients. Thank you.
Thank you. Minister, do you wish to respond, or do we hand over to Dr. Karim?
I think it's my last comment now. I think I just want to thank firstly the members from the community, especially the last point. And also, I think there were also other brilliant ideas, for example, in terms of using biometrics and so forth. That will also not only help not only the province, but throughout, especially the National Treasury, when they fund the provinces per head count, they often not include these kind of packages of health services that are being rendered outside the health system, because, like as the members have alluded to, it's completely different. You cannot just transplant what is happening at the facility compared to what is happening outside. So thank you very much for the input. And also I will urge, because some of the members, they are serving in these other structures at a national level in different caps, that probably they need to push this issue of leaving behind the community health workers by the health system, so that the national could be able to make sure that they rush in regard to this aspect. And also with the unions, because the other part of our is about the unions, some of the unions will be just coming to provinces that demand that they need to be absorbed, yet they know they are part of the bargaining chambers. And they're also the ones who are the drivers who could be able to drive and expedite all of this. So it needs all of us to work, because all of us who are here for the community health workers, which indeed they help us throughout. And then for the for my colleagues in the House, I will actually even I did encourage you to write to the national. I think there's a DDG for primary health care. I think she's back now. She's very passionate about it. She used to be the administrator for the other provinces, departments then, who started from the whole of this process. But the issue is about, whilst we might have the overall DDG who has got the whole understanding in regard to policies and so forth, but we'll find that there's various issues of the packages. You get different people, like you get those community health worker people in the national who are in charge specifically only for community health workers working in the HIV/AIDS sector. And then for all others in the mental health is another. So probably just maybe to make sure that when they bring, when you write to them, you need to be specific in regard to exactly what needs to be, you want them to have, to present, so that you become specific. And also in additional, Chair, it doesn't stop to also to call some of the unions specifically who are dealing with it, because not all community health workers, for example, actually there are fewer, maybe Nehau or the, I'm talking about the bigger ones, but with the NUPSOs and so forth, but specifically for those who are part of the province and also those who are part of the National Bargaining Council. And then lastly, you can also even invite someone from the Department of Employment and Labor in regard to where's the process now, so that we don't come back and have this conversation again, and then we do the blaming and whatever, all of those, because we are part, as we know that health service is a concurrent function of the national and the province. For us, we render the services. The national is in charge of the policy, the norms and standard. Thank you very much, Chair. Thank you to the department for the presentation and also for responding to the questions. Thank you, Chair.
Thank you, Minister. Dr. Karim, before you respond, I see there's one more hand. Please proceed. That's right.
Thank you, Mr. Chair. I'm Pumza from PL HIV sector. I just want to know about the prisons. Is under Department of Health or is under NGOs? Because in prison, all the services of HIV, TB is no longer done. There is only one counsellor that is there. All were lost their jobs in 2019 because the NGO that was working there, they said there's no money to pay the counsellors. And also one of my neighbors come from prison with EMDR, TB. I was asking him, did you tell them that you were on TB treatment? He told me that no, I did, but it's only one counsellor and is at another center because it's 5 centers there in Baltimore. So that counsellor has to go right around those centers to do those services to the patients, to the prisoners. Thank you, Chair.
Thank you, Dr. Karim.
I think probably, can I answer that one, Chair?
Sorry, Minister, please proceed.
Okay. Can I respond to that one and then Dr. Karim can continue? Because I want to highlight that in prison, if you are still awaiting trial, it means you are still under SAPS. So all of those overcrowding and everything that is happening there, it's the whole of that space is under SAPS. And then once you are convicted, now you go to prison, then it means you are under correctional services. But on the health aspects, it dovetails at the national level. In as much as that there might be some other components where you'll have the delegated functions, but it's a national health, correctional service, and the SAPS, depending in terms of where exactly. Then Dr. Karim can add more.
Thank you, Minister.
Thank you, Minister. Thank you, Chair. So just with regard to blood pressure monitoring, I mean, I'm looking at the scope of practice of the community health workers. Yeah, I'll certainly take it back to our team because at the moment it's around awareness of hypertension and the complications of hypertension and screening for hypertension. But also along with utilizing a blood pressure machine would obviously go some training and a deeper understanding of what the readings mean and when to refer, because there are certain cutoffs depending upon age and comorbidities. It's not a simple matter of just putting a cuff on an arm. One must have a deep enough understanding to know when to refer a patient, because my blood pressure, for example, would be different from someone who's 10 years older or 10 years younger. And one must be able to have an understanding of what the cutoffs are and the limits are. So yeah, but I will take it back to the team looking at the scope of practice, Chair. NPOs must be held to account. Absolutely, couldn't agree more, and that's been part of our whole process of what we presented today and why we focus on governance as well. And Minister answered the question on prisoners as well. But Chair, I just want to thank you. I mean, before we lose the opportunity, it's important that through the legislature to grant communities access to ask the questions in the right places so that we can respond to what's being said on and what the needs are of the communities. It's important for us as a department, through yourselves as the legislature, because ultimately we're here to work for, we're all here for the same purpose, and we really want to improve the health of and lives of people, and the community members know what the needs are in the various communities. So that's an important process for us to hear and listen to the range of issues that were addressed to us today. We've certainly made some, like 4 pages of notes here, and we will certainly be taking these issues back into our process. So I just wanted to use the opportunity to thank you, Chair, and members of the legislature.
Thank you, Dr. Karim. Members of the public, thank you for joining us at this meeting. Thank you for your sacrifice. If I'm going to say something, your urgency and your commitment and your energy is palpable and is commended. Thank you for what you do on behalf of the people around you. The same applies to our minister. Energy, commitment. Minister, I cannot thank you enough. Urgency as well. I cannot thank the minister enough for the absolute strong leadership and clear leadership that she's giving us. Members of the public, on that note, the committee has some other work which I'm sure you won't be interested in, and you are welcome to take part of us, take leave of us rather, and as much as Dr. Karim has indicated his gratitude, I want to, on behalf of the committee, express our gratitude to him and his team, and also to Dr. Furfrey. That's a tongue twister for me. Apologies, Dr. Furfrey. I want to thank you, and please carry back to your department and to your colleagues our deepest gratitude and appreciation for the very thorough work that you do. Thank you very much. Can I request the members to take their seats, please?
Yes.
Members, can you please take your seats? Members, can you please take your seats? Thank you. Members of the public, members of the public, the meeting needs to continue. Thank you. Thank you.
Bye-bye, sien julle.
Now we adopt the minutes.
Yes. Can members please take their seats so that we can proceed? Thank you, members. We move to item 10 on the agenda, or then the meeting plan, which is, I must actually first ask for whether there are any resolutions in terms of the presentation. Member Windvogel?
Okay, I think Dr. Karim, I'm not sure, was the minister, proposed that we invite national government on progress made in terms of the negotiations. So I will propose that or recommend that we invite them, because you can see it's a burning issue. The absorption of healthcare workers. Yeah.
Thank you, Member Windvogel. Are there any other resolutions, colleagues? Member Plato?
Person is one issue that was clear from the meeting is implementation of what's discussed. Everybody's of the opinion it's a beautiful plan, it will make a difference. Implementation is key. But I think we need to caution, and I think we need to talk about it again, the request from the public, from the organizations, the request with one is absorption, but also other resources. I was hesitant to say, listening to some of the speakers, we just don't have the budget for that. We don't issue about cars, issues about blood pressure machines. How far do we want to go with community health workers? I think we just need to be a little bit cautious about it, but also we need to discuss it to say to us what it is we want, what is feasible. And maybe a rider to that is to note what it is other provinces are doing. I think one theme that I think 3 or 4 people mention it. This and that is happening in other provinces. Why not in the West? Why is the West different? So I think the officials need to do a check of what's happening in other provinces with regard to community health workers, how they are using the community health workers. Are we on track? Are we on par? Or are we far behind? Thank you.
Thank you, Member Plato. Member Klaas?
Yeah, thank you, Chairperson. According to what I heard on the public is that the NPO, there is a problem with NPOs. Because the NPOs, some of them, they only look after their own material, not about laborers. Who's doing the work, how, and what needs to be serviced, like phones, cars, and other stuff that must be assisted to deal with the problem. And even the security of the workers is not safe, according to what I heard. And also that I want just to highlight is that for them to be so in this manner, it needs I don't know what meeting I can call is that it must be like in Bizo, where all of stakeholders can make a big tent. All of stakeholders are there because sometimes this information is not all of them are in. Because NPOs are not here, maybe when they can come, they can protect themselves, and then at that time. So if they will be like Mbizo, big Mbizo, and then we talk to all of us, whatever resolution we take, and then we implement. The last thing that I want to engage on is that for me to be here, it's the first time, but I need maybe the background, no matter not now or to those who are the stakeholders. What was the agreement? What have you agreed upon lastly in order for me to see you that when we are in the meeting, we are doing progress? Because now for me it's the first time and then I hear this thing. So sometimes things have been agreed and not implemented. That's the reason I said that even no matter it's a documentation saying that we will have a sitting, we agree on point, and then in order for me when in the meeting to see, oh, they are on good progress or not. Because when the community, the public is always complaining as if that there are things that's supposed to be done and are not be done. And I will support mainly Mr. Plateau about, we have to check Western Cape province, not only on health, why they are different from other provinces. Even anything in the Western Cape is not the same as other provinces. Even we call it ministers here, others they call them MEC. It is good because I understand they did constitution, but they must also in line with what government is doing. It must not a minister that is doing its own thing that is not in line with the constitution. Thank you.
Thank you, Member Klaas. Member Windvogel.
The NHI, the implementation of the NHI. And now you can see the benefits of NHI if it comes to even the community healthcare workers. But nevertheless, it's actually good that the Western Cape government do agree that we need the NHI. I will also propose or recommend, Chairperson, that we need to engage the NGOs. Because it's not the first time when we go into oversight, you will always have a worker whispering in your ear, we are not treated well here. And now you could have hear from some of these people, that's the issue. I'm not sure if it is that we need the department themselves to engage with the NGOs. In a previous speech, I mentioned, of a previous meeting, I mentioned it to the department. We are giving money as a department to the NGO so we can prescribe to them, or we are actually prescribing to them how to use the money. And if we are saying in the budget 100,000 is for salaries, that's how it needs to be spent. Because the issues was raised that some people are getting less than the required minimum wage. So I'm not sure how to put it, but I think there needs to be a session with the NGOs and MPOs. Yeah.
Thank you, Member Windvogel. We will come to the program a bit later, but I think there in July on the program there is an opportunity where this will most probably be discussed. But that's for a moment later. Are we done with the resolutions? Thank you very much. Then we move, members, we move on to the the consideration and the adoption of the following committee documents, which were made available to you. Firstly, the minutes of the meeting on the 1st of February 2023. Can we have a proposer there? Councillor Plato, and seconded by Councillor, not Councillor, Member Fry. My apologies, Member Plato. I'm still in retro mode, I see. My apologies for that. Then we move to item 2.2, which is the committee program, which you have also seen. If we can perhaps work through that. Before we do so, the meeting of the 3rd of March has to be postponed due to the strategic planning session that the department planned before receiving the invitation. So the HOD and other senior management will not be able to attend that meeting. So that meeting has to be postponed to a later date. Are there any inputs or comments, members, on the program? Member Windvogel?
In terms of oversight, I see our program is packed actually up until March. Is it March, April? But I think Kobela and Robertson, we need to do an oversight there. It's one of the clinics that we need to do an oversight. So I'm not sure where we're going to fit it in. It's now for more than a year that I'm trying to
please proceed, Ms. Jamse.
Through you, there is an, let me see, okay, the last page, the back page, it's just because now the parliamentary program is so busy, it's like bloated, so we keep on shifting things down. But for the visit to Boland and Gobela, all that, I remember during the previous chairperson's tenure, there was a proposal that the committee needs to visit that site. So, but now it's here in September. I'm not sure whether it will still be in September or maybe the committee will find a date before September program.
Thank you, Ms. Jamse. Member Windvogel?
Thank you, Chair. I think September is too far, Chair. We really need to speed up these processes of us. If I look at us, we are meeting on most of the time on Fridays. What are we doing the other days? Let's say, even if we have to take our Mondays. I'm not sure, but really it can't be September. And it's now for more than a year that we are trying to get to the Boland area.
Chairperson,
Member Plato?
Maybe help if the member would agree that we don't need to go to the Boland necessarily for 2-3 days. Maybe if we leave early the morning, 7 o'clock the morning, we're there 9 o'clock, do the oversight, return the afternoon. If the administration could probably looking at something like that.
That's a valid point and a welcome input, Member Plato. We will certainly have a look at that. If that is in order with Member Windvogel. Thank you. Thank you. Noted. There's nothing on the third.
Chairperson.
Member Klaas? Would you switch on your microphone, please?
I wanted just to add that it's in Langeberg. Gubela is close to Zolane. For the visit, if you can just say that we will just tackle 2 clinics that are close to each other. Because what my fear is that you will go there and go back and leave the other one while you were around, because it's Langeberg. Thank you.
Your point is taken. We will look at the logistics and the time available. Thank you. Members, if we move on then to the program then again on the 10th of March, you have it in front of you. I'm not going to read everything. Then on the 20th of March, there's the deliberations on the vote. That's also the day of the by-election in Swellendam, where the special votes takes place on the 20th, because the following day is a public holiday. So that's certainly something that we have to take into consideration. I'm not sure when another window will be found, because it is, after all, it is the budget. No, but seriously, that is something that we have to consider. And then later that week, in fact, on the Thursday, there's the finalization of committee reports on the appropriation bill. And then again, after Easter, we meet again with the department doing a briefing on the mental health challenges in the province. Are there any comments? On the 21st of April, the Standing Committee explores the legislative implications affecting mental health and psychiatric care. On the 28th, unannounced health visits or health facilities visit in the Cape Winelands. On the 5th of May, another unannounced meeting, facility in the Oeverberg. And then basically a month later, there's a proposed Karoo sub-district oversight visit. Ms. Jauche, is that going to take place? You can't. That's fine.
I have no idea, Chair. It's going to depend on the availability of dates.
We take note of that. Then when the legislature reconvenes in July, that's the briefing that I referred to earlier by the various stakeholders, where we will obviously get the NPOs and everybody involved. And then we only have September left, it seems, at this stage. Can we provisionally adopt this and then make the necessary amendments as we go along? Member Klaas? Oh, did you just agree?
Yeah, I adopt the agenda to be approved, a program to be approved.
Thank you very much, Member Klaas. Seconded by Member Fry. Members, with that, this meeting is adjourned. Thank you very much for your presence. Thank you. Thank you. Thank you. Thank you, Ms. Jamche.
Thank you, Chair.
And Maria. Thanks, Nombu.
Thank you, Chair.
Thank you so much. You don't have to get up for me.
The reason why the Poland was like 2 days or so is because there's so many. Then I don't know, but the program is
sometime next week.
Yeah.
I will call you by Monday.
But for social development, the budget is.
Yeah. You will.